yang ada kasih.
Pintunya nggak ada.
Ahlan wa sahlan. Welcome to International Guest Lecture in Faculty of Public Health, Universitas Muslim Indonesia. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. The Dean Faculty of Public Health, Universitas Muslim Indonesia, Dr. Suharni Apah, SPDMKes, and as well as the Vice Dean Faculty of Public Health, Universitas Muslim Indonesia. The Honorable Guest Speaker, Mr. MDUDUZI Colani, PhD Candidate MSc BNSC RN. The Honorable the Chairmen and Secretaries of Study Program within the Faculty of Public Health, Universitas Muslim Indonesia. The Honorable Chairman of Quality Assurance Faculty of Public Health, Universitas Muslim Indonesia. The Honorable Chairman and Secretary of Research and Journal Management Center of Faculty of Public Health, Universitas Muslim Indonesia. The Honorable Lecturer, Faculty of Public Health, Universitas Muslim Indonesia. The Honorable Ladies and Gentlemen. First of all, let us give thanks for the presence of Allah Subhanahu wa Ta'ala. It is because of the abundance of grace and guidance that we are still given help and the opportunity to take part in the international guest lecture with the topic the first socio-behavioral and mental health impact of COVID-19 among the general public and healthcare workers in Eswatini, Southern Africa. Greeting and prayers, do not forget that we also treat our Lord, the great Prophet Muhammad Sallallahu Alaihi Wasallam, who has brought us from era bright as it is today. Ladies and gentlemen, next is singing together with the national anthem of Indonesia Raya to be continued by Mars. Ladies and gentlemen, please stand up. Gentlemen, sit down, please. Ladies and gentlemen, next agenda is report by the chairman of committee by Dr. Andi Reski Amalia SKM MKes. Times is yours.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Senator Mr. Muslim Indonesia and all staff, Lecturer of Faculty of Public Health, Universitas Muslim Indonesia, the Honorable, our guest speaker today, Dr. Shongwe, PhD, candidate MSc, BNc, RN. The Honorable all distinguished guests, fellow students, and alumni. First of all, let's deliver of greatest thanks to Allah Subhanahu wa Ta'ala, most merciful, because of with His permission today we can gather here to join for the international lecture event which held by Faculty of Public Health Universitas Muslim Indonesia. Secondly, salawat and salam be with our Prophet Muhammad SAW, who was distinguished from the darkness and likeness and from immoral to moral society. Ladies and gentlemen, the time we raised in the international guest lecturer is much related with our current situation, and this event is very special for us because this can be as a part of our faculty anniversary. In addition, there are also approximately more than 100 participants who take part in this international guest lecture today. It consists of students, lecturers, and health practitioners, as well as we are so glad that some international friends also attended this international guest lecture. Furthermore, we would like to express thanks that there are still a lot of technical mistakes or other mistakes during this event. For that, we want to express our apologies. All in all, I believe all attendees of this international guest lecture will obtain great benefits and a lot of knowledge from this event. And once again, we would like to express our thanks to Mr. MDUDUZI for your time, knowledge, and experience that you will share to us today. I think that's all. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh.
Thank you for the chairman of the committee. Ladies and gentlemen, next agenda is speech by the head of the Public Health Study Program, Universitas Muslim Indonesia, by Dr. Andi Surahman Batara, SKM MKS. Times is yours.
Thanks. Assalamualaikum warahmatullahi wabarakatuh. Good morning all. Praise be to Allah Subhanahu wa Ta'ala, Almighty for all His powers, so that today we are still in good health and given the opportunity to attend this event. Salawat and taslim we send to the great Prophet Muhammad Sallallahu Alaihi Wasallam. Hopefully all of us will be given intercession in the hereafter. The Honorable, the Dean of Faculty of Public Health, Universitas Muslim Indonesia, the Honorable Head Department of Faculty of Public Health, Universitas Muslim Indonesia, the Honorable, our guest speaker for today, Mr. MDUDUZI, the Honorable distinguished guest, Chairman of the committee, all committee members, all lecturer, staff, and students of Faculty of Public Health, Universitas Muslim Indonesia. COVID-19 has become a global pandemic. In Indonesia, a few days ago, COVID-19 was celebrated its first birthday. But of course, we all pray that COVID-19 will not live long. The topic of our guest lecture today is very relevant to the global problems that we are currently facing. Once again, I would like to send my big thanks to the speaker who are willing to attend and share his knowledge. I know that the Mr. MDUDUZI is an expert in COVID-19, especially the effect of this pandemic to social behavior and mental health of general public and health workers. because this is a part of his dissertation on COVID-19 in Eswatini. We want to express our warm welcome to Mr. Duduzi, and I am the head of Public Health Department. Again, want to say thank you so much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Ladies and gentlemen, next agenda is speech by the Dean of the Faculty of Public Health, Universitas Muslim Indonesia, as well as opening the international guest lecture by Dr. Suharni Afahrin SPD MKes. Times is yours.
Baik, saya tes dulu suara saya, kedengaran di sana bagus.
Bagus, Ibu.
Iya Bu, kedengaran.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
First of all, let us say thanks to Allah Subhanahu wa Ta'ala, which has given guidance and blessing to us. Therefore, we can gather together, even though by online, without the threat of any. Our salawat and greeting are always delivered on our great Prophet Muhammad Sallallahu Alaihi Wasallam, which has brought us from darkness to brighter. Bismillahirrahmanirrahim. The Honorable, the Head of Public Health Department, Nursing Department, and Midwifery Department, Faculty of Public Health, Universitas Muslim Indonesia. The Honorable, our guest lecturer, Mr. MDUDUZI Colani. The Honorable, distinguished guests, all lecturers, staff, and all students of Faculty of Public Health, Universitas Muslim Indonesia. Good morning, ladies and gentlemen. First of all, I would like to welcome you all to this international guest lecture held by Public Health Department, Faculty of Public Health, Universitas Muslim Indonesia. I am particularly delighted with this event. I would like to express my biggest thanks to Mr. Duduzi Colani for your time and willingness to share your research experience and the result to us. I believe from your lecture, we can obtain so much insight and knowledge. In addition, I would like to express my biggest thanks as well to the committee and to everyone who will be working and support this event. To be honest, I am very proud and glad that we can invite a foreign lecturer to sharing and discuss with us. Therefore, we are, as academicians, can broaden our horizon and learn from the other. Again, thank you very much for all of you, ladies and gentlemen. Thank you for attending and participate to this event. Be saying, Bismillahirrahmanirrahim. I open this international guest lecture. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Welcome to International Guest Lecture in Faculty of Public Health, Universitas Muslim Indonesia. Guest speaker, Mr. MDUDUZI Colani, PhD candidate, MSc, BNSc, RN. Ladies and gentlemen, next agenda is prior recision by Dr. Haji Muhammad Kidri Alwi MKes. Time is yours.
Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Okay. Ladies and gentlemen, let's pray to God together that we will get a blessing today. Mari kita sama-sama menghadirkan hati kita yang dalam memohon kepada Allah agar diberikan keberkahan pada hari ini, acara International Guest Lecture. Semoga Allah berkahi dan memudahkan semuanya. Ya Allah, O Lord, praise be to you, preserver of the universe, praise for the gifts and pleasure that you bestow upon us. Praise be to you, Majesty. Praise be to your glory and power. Ya Allah, ya Tuhan kami, segala puji untuk-Mu, pemelihara alam semesta. Segala puji atas karunia dan kenikmatan yang Engkau limpahkan kepada kami. Segala puji atas keagungan-Mu, segala puji atas kemuliaan-Mu dan atas kekuasaan-Mu. Allahumma salli wa sallim wa barik ala sayyidina Muhammad wa ala alihi wa ashabi ajmain. Ya Malikul ya Kudus, kami agungkan nama-Mu pada hari ini hanya karena Engkau lah Tuhan kami. Hanya kepada Engkau lah kami sujud, hanya kepada Engkau lah kami bersyukur atas semua nikmat yang Engkau berikan kepada kami. Pada hari ini kami berkumpul dalam webinar untuk mengikuti rangkaian International Guest Lecture. Dengan sesungguhnya kami memanjatkan puji dan syukur atas nikmat-Mu yang tak terhingga yang telah Engkau limpahkan kepada kami. Ya Allah, mudahkanlah semua acara ini, berkatilah ilmu-ilmu yang kami dengar, sehingga kami dapat mempraktekkan dan dapat juga mewariskan kepada murid atau mahasiswa-mahasiswa kami. Ya Allah, berkatilah dan berikanlah rahmat inayah-Mu kepada para pembicara yang telah memberikan ilmunya kepada kami semua. Dan semoga apa yang kita lakukan pada hari ini mendapatkan nilai berkah, sehingga kita dapat kembali untuk bisa memahami begitu luasnya ilmu-ilmu yang Allah berikan kepada hamba-hambanya, dan kita bisa share pada acara International Lecture ini. Rabbana hablana min azwajina wa zurriyatina qurrata a'yun waj'alna lil muttaqina imama. Rabbana Rabbi auzi'ni an syukra ni'matika allati an'amta alayya wa ala walidayya wa an amala shalihan tardahu wa adkhilni bi rahmatika fi ibadika shalihin. Allahumma rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina azabannar. Alhamdulillahi rabbil alamin. Al-Fatihah. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Ladies and gentlemen, then we will enter our core event today, the International Guest Lecture with the topic the perceived socio-behavioral and mental health impact of COVID-19 among the general public and healthcare workers in Eswatini, Southern Africa, guided by Reski Aulia Yusuf, SKM MKes, as the moderator today. Ladies and gentlemen, before I invite, I will read a short curriculum vitae from our moderator today. Reski Aulia Yusuf, SKM MS, alumni Bachelor degree from Faculty of Public Health, Universitas Muslim Indonesia, alumni Master degree from National Yang Min Chiao Tung University, Taipei, Taiwan. Ladies and gentlemen, I invite to Reski Aulia Yusuf, SKMMS, to guide the next event.
All right. Okay, thank you so much for Master of Ceremony for the invitation. So I'm sorry, I will open this mass to Mr. MDUDUZI.
Hello.
Good morning.
Morning, everyone. Hi. Can you hear me? Hi, Reski. Can you hear me? Reski, can you hear me?
Kalau misalnya ada yang mereka percayai, kemudian dia awalnya MSis lalu dengan melakukan tradisi seperti itu, ternyata betul dia tidak MSis. Kemudian apa kaitannya dengan peminatannya?
Andi Asrina itu tolong ditelepon dulu deh itu Andi Asrina.
Iya, mungkin.
Anda sudah dicari ya?
Suruh unmute kenunya, suruh unmute.
Unmute kenunya Anda Srina masuk ya? Langsung.
Terkait dengan masalah hormon, masalah perempuan.
Karina, tolong kita unmute ki anu tadi tempat lain, masuk suara tadi di Zoom meeting internasional. Karina, sudah enggak distorsi nih? Enggak nih kayaknya.
Apa kaitannya dengan dominannya ASRI ini? Saya minta dijelaskan secara keilmuannya terkait hormon yang berpengaruh di dalamnya.
All right, everyone. We would like to apologize for this inconvenience because of there is error on the Wi-Fi. So, Mr. Mdu, can you hear me?
Yes, I can hear you very well.
Okay.
Can you
so
hear
much
me?
And yeah, I can hear you very well.
Thank you.
I'm so sorry for this inconvenience. We apologize.
No problem at all.
Okay, thank you so much. So, ladies and gentlemen, so before we start the presentation of our guest lecture for today, so in order to avoid any disturbances during the lecture later, so I would like to ask you, all the attendees, all the participants, to mute your voice, and also please turn on the video because we want and face on the Zoom. So to make it interactive, please turn on your video, please. Okay. Okay, all right. Thank you so much. So let me begin the guest lecture for today. So the Honorable, the Dean of Faculty of Public Health, Universitas Muslim Indonesia, Ibu Dr. Suharni Afahrin, SPD MKes, the Honorable, the Head of Faculty of Department, Universitas Muslim Indonesia, Dr. Surahman Batara, FKM MKes, and the Honorable all the head of department, Faculty of Public Health, Universitas Muslim Indonesia. And of course, the honorable to our guest lecturer today, Mr. MDUDUZI Colani, PhD candidate, MSc, BNSG, registered nurse. And the honorable for all lecturers, staff, fellow students, and distinguished guests of Faculty of Public Health, Universitas Muslim Indonesia. And Assalamualaikum warahmatullahi wabarakatuh. All right, good morning, ladies and gentlemen. How are you today? Okay, I hope everyone is good. So to make the atmosphere become more relaxed and also full of enjoyment, please shaking your hand to the camera and say hello and thank you to our Mr. Guest Speaker, Mr. MDUDUZI. Thank you so much for your time and for your willingness to join with us in this guest lecture. And before we jump to the session of the guest speaker's presentation, we would like to take some picture, Mr., for documentation. So everyone, please turn on your video because we want to see your beautiful and handsome face. Please give your big smile to the camera because we want to take the picture. Yeah. All right. All right, 1, 2, 3, please smile. All right, thank you. I can see the beautiful and handsome face on the Zoom. All right, thank you so much. I think that's enough because it's more than 100 attendees attend this guest lecture, international guest lecture for today. Awesome. All right. So thank you so much for everyone. So first of all, again, I would like to welcome you all to this prestigious international guest lecture held by Department of Public Health, Faculty of Public Health, Universitas Muslim Indonesia. So in this occasion, we shall have outstanding guest speaker from Eswatini, and currently studying in National Chiao Tung University, Taipei, Taiwan. And I believe he will enrich our insight and also give her his knowledge about regarding the topic today. So before the presentation begins, please allow me to introduce the presenters. All right. So, Mr. MDUDUZI Colani is currently a third-year PhD candidate in Public Health, National Yang-Ming Chiao Tung University in Taipei, Taiwan. And he is also employed as a lecturer in Department of Midwifery, Science, Faculty of Health Science, University of Eswatini in Southern Africa. And where has been teaching applied research and evidence-based practice, quantitative and qualitative data analysis, and epidemiology, and among other courses. And he holds a Master of Science from Taipei Medical University, Taipei, Taiwan, and Bachelor of Nursing Science in Advanced Medical Surgical Nursing with Midwifery, the University of Eswatini. And in 2018, he was awarded the Taiwan International Cooperation and Development Fund, ICDF scholarship, to pursue his PhD studies in Taiwan. And because of this scholarship also, we can meet each other in Taipei, Taiwan, in IHP, International Head Program, National Chiao Tung University, Taiwan. Thank you, ICDF. And Mr. Colani is a young upcoming social epidemiologist with several years of clinical research experience. And he is a public specialist and nurse with expertise in research, statistics, epidemiology, social and behavioral science, nursing research methodology, advanced medical surgical nursing, and midwifery. Amazing. And his research interests include socio-behavioral determinants of health, adolescence delinquency, parent-child processes, risky sexual behavior, sexual violence, and reproductive maternal, neonatal, child, and adolescent health. And I still remember it vividly, right? Me and Mr. MDUDUZI took the same class in adolescent health. And to be honest, at the time, he gave me a lot of insight and knowledge for my master thesis. Thank you so much, Mr. MDUDUZI. And he published several peer-reviewed articles in international referred journals and has presented scientific papers in local and international conferences. Wow. Such a brilliant and very professional person in health fields and very colorful biography. All right. So without a further ado, I would like to welcome our guest lecturer, and he will deliver a presentation entitled The Perceived Socio-Behavioral and Mental Health Impact of COVID-19 among the general public and healthcare workers in Eswatini, Southern Africa.
Yeah.
So in this occasion, Mr. MDUDUZI will share two.
Baru mau mulai ini.
First, he will share it's about the impact of pandemic COVID-19 to the social, behavioral, and mental health impact among the public and also especially for the health workers. And the first study is a cross-sectional study, population-based telephone survey of 1,003 adults 18 years and older during the first wave of the pandemic in Eswatini. All right, without a further ado, please, Mr. MDUDUZI, time is yours. Thank you.
Thank you so much, Program Director or Moderator, Reski. And good morning to everyone. Can you hear me first before I speak a lot yet? Maybe you don't hear me.
Yeah, we can hear you, but you can make it louder also.
Okay, is it now better?
Yeah.
Okay, thank you so much. Can you see my screen?
Yeah, we can see it.
Thank you so much. Salamat Panjituan Tanyonya, the Dean of Faculty of Public Health, and all protocol observed. Good morning, ladies and gentlemen. I would just want to thank you for the honor and your kindness to invite me to share my experience during this COVID-19 when I was doing research in Eswatini, even though I was still here in Taiwan. It is my pleasure today to share to you how we have been tackling COVID-19 in Southern Africa, in Eswatini. I also want to thank the School for Public Health and the Dean and the committee for the webinar who agreed for me to be able to share with you my experiences today. And I want to also thank you, Reski, for inviting me. He was my classmate here in Taiwan, and she was one of the kindest people I met in Taiwan, and we still miss her here in Ming. And with no further time wasted, ladies and gentlemen, if it is okay to you, moderator, I can now start my presentation, right? Reski?
Yes, sorry.
Can I go ahead, right? Can I go ahead now, right?
Sure, you can do it, yes.
Okay, thank you so much. All right, today I will just share two experiences regarding two studies that we conducted in Eswatini during the pandemic. So the title combines both studies. So we look at the perceived social, behavioral, and mental health impact of COVID-19 among the general public in Eswatini and also among healthcare workers in Eswatini in Southern Africa. So the social behavioral means that we are going to look at both social and also behavioral aspects and also the mental aspect of the pandemic in Eswatini. And I will not say much about myself because I think the moderator has well introduced me and even said very kind words about me, and I thank you for that. But I should say that I'm a student here at the National Young Ming Chiao University, and my advisor is Professor Song Ling Huang, who is a full professor here in the Institute of Public Health, who has been the one guiding me throughout this research. And the outline for today will just be the normal outline for studies that I used to, but I will have to give a brief background about Eswatini because almost maybe a majority of you, I guess, have never even visited Eswatini, but I can hope that maybe after this presentation, you'll be interested to visit our beautiful kingdom. So I'll give a brief background about Eswatini, and then I'll also share a brief background about the studies that we conducted. And also then I will give a brief about the methods for each study separately, and then the results and recommendations. So for now, I will just present the first part about the first study, and then we'll take some few questions, and then some maybe 5 minutes break, and then we can move on to the second study. I pray that I don't keep you long and that I do not make you sleep during the presentation. So as a start, Eswatini is located in Southern Africa, as I've already said, and it is one of the last absolute monarchs or kingdoms in Eswatini. So it is located around this southern part of Africa, and it is actually surrounded by South Africa, almost as you can see here that almost all this side is South Africa, and then this is Mozambique. So we do not actually have an ocean or a sea that is marking the borders of the country. So we are within South Africa and also Mozambique. So our official name is called Kingdom of Eswatini. Africa is known for its natural reserves with animals, that's called the Big Five. So I should say today that Africa is not one country, but it is the entire continent you see here. And then there are about 53 countries in this particular continent. And Eswatini is one of the tiniest and smallest kingdoms within this continent. And this is our national flag, as you can see. And then moving on, Eswatini actually is about 17,350 square kilometers. I guess it's about 100 times less than Indonesia. And it has about 4 administrative regions that you can see here. So these are the regions. So our capital city is located in this north region, which is called Hoho. And it is a lower middle income country. And we have a population of about 1.1 million, I guess, about 200 times less than that of Indonesia. And our population is, the majority of them are living in the rural area, so along the countryside. So most people are living in these particular areas, but the rural areas actually are spread all over the country, but they are mainly rural. And a majority of the people in Eswatini are Swati, meaning, like for example, in Indonesia, I would say Indonesian, for us, we say Swati. So those are the people who live in Eswatini. So we have very few whites, for example, about 3% of those from Europe. So, but mainly the other group is made of people who are living in Eswatini, who are coming from the other parts of Africa. The most dominant religion is Christian. Actually, the country regards itself as Christian, and we have about 0.3% people who believe in Islam. And most of them actually are expatriates or people coming from other countries like in India. And then also in Pakistan. And then also the country is a fairly a young population country because the median age of the population is about 22 years. And then majority or slight majority of them are women. Actually, this has been shrinking over the years. So we are now men are now catching up to the women in terms of the sex dependency ratio. And here I must correct this typo. Actually, the men have a lower expectancy than women. So women have about 60 years, men have about 55 years. So please correct that in your slides. And this is our beautiful capital city. We call it Mbabane. So it is a mountainous place. So I hope one day you can come and visit this place. It is where most of the government offices and government official business is actually conducted in Eswatini. And English in Eswatini is one of the major language along our language, Siswati. So you can use either language when you're doing business in Eswatini. And I should say that even though this is the capital city for the government, but also because we're a kingdom, we have a king. So there's also a traditional capital, which is known as Lubamba, where the king resides. So some decisions that are traditional or cultural are made in that other part of the country. Before I go on much, I want to share with you some of these things you know, so I will quickly go over those and then I will focus on the issues in Eswatini. I want to share the timeline regarding COVID-19 in Eswatini actually, but before that, let me just share about COVID-19 globally. You remember that it was China alerted WHO around 31 December about the several pneumonia cases in Wuhan. And on 30 January 2020, WHO declared SARS-CoV-2 as a public health emergency. And later, a few days later, WHO named the disease COVID-19. And about a month later, WHO declared COVID-19 a pandemic. And in Eswatini, we actually had the first case on the 13th of March, but it was officially reported on 14 March, but that is the first case that we had in Eswatini. So it took a little bit of some time before the virus could reach Africa. And Eswatini, I think, was one of the countries that were infected, not in the first phase of, but a little bit later. And after that, about 4 days later, the king declared a national emergency through the Prime Minister's office. And that also then about a few days later that the country entered a partial lockdown. So it was not full lockdown, but most of the services were actually banned from opening and also restricted, like schools were closed. So mainly it was everybody at home, but some essential service was taking place, like truck drivers crossing the borders and healthcare workers, and public transport was limited to certain hours of the day in the morning and afternoon only. And then around 15 April, the government of Eswatini actually relaxed the partial lockdown. So a few days later, relaxed the partial lockdown and however, still extended it to about 21 days at that time. So the reason why this 21 days is in red is because it was set 21 days, but up until today, it was never actually lifted up or fully stopped. And then around 16 April, we recorded the first COVID-19 death in Eswatini. And after this lockdown, actually, the cases here between 27 March and 15 April, they seem to be stable. And then the government, that's why, relaxed the lockdown. And even on 23 April, they further relaxed the lockdown, meaning they opened more businesses at this time. However, soon thereafter, the government also continued to relax the lockdown measures even further. So it was more like almost everybody was doing whatever they wanted to do in the country. However, even 21 March, almost everything went back to normal, even though nothing officially was said. And on 25 July, the government actually changed the COVID-19 guidelines because they were seeing that there are now more cases of COVID-19. So they wanted the hospitals to be able to manage. So what they did, they then changed the guidelines, for example, to say, if you are having COVID-19 symptoms, and you can be tested only if you have symptoms. And also that even if you have a contact of someone with COVID-19, if they are positive, but you are not yet positive and you don't have symptoms, you cannot be tested even though you are in contact. So they tried to limit the number of people who can conduct the test because the healthcare system was getting overwhelmed at this time. And around September, November, everything like that after seemed to be normalizing, or the curve was flattening. And the first wave was seemingly going down until in December, when the beginning of December, we saw a very, very steep rise of the cases in Eswatini, as you will see in a later slide, that the cases actually doubled between December and January this year because of the relaxation of the measures. And we had the festive season, so we celebrate Christmas around this time. Also, the country held a lot of events in this country, national events, whereby everybody was gathering together to celebrate the country's traditions. So there were also a lot of cases seen at this time. So the government, after seeing that now the cases were going up and the second wave was very severe, as you will see in the slides, was very severe, they then now reinforced or now said, let's go back to the strict partial lockdown. So there was a strict lockdown between January and February. And so far, the cases have been going down, and the partial lockdown is still in place even today. It was just extended this last week, actually, to the next 2 weeks. So we are still on partial lockdown. So maybe you're wondering, how are the cases in Eswatini? So as of yesterday, because I updated this because we have the one for Saturday. So this morning I updated this. So as of Saturday, of yesterday, we have about 17,000 cases in the country and about 658 deaths. So that's about 3.8% fatality rate. And also then we have about a recovery rate of 88.9%. So the most affected region is the capital city is mostly affected, followed by this region, the Manzini region, which is the major industrial area in Eswatini. Initially, during the first wave, actually this was the region, the industrial area, this one, because it's the most populous region. Manzini is the most populous region. It was the hardest hit during the first wave, but things changed in the second wave, and this particular region now, where the capital city is located, is now the one that is mostly affected by this pandemic.
Can you hear me?
Yes, I can hear you, Reski.
Sorry for disturbing. And can you make it slower? So.
Oh, okay, no problem.
Yeah, for the presentation. Thank you so much.
Okay, thank you. I should apologize. Because I am a natural fast speaker, but I will try my best. Thank you so much. I'm sorry about that. All right, thank you. So basically now the country is having this number of cases. And then maybe I should also give you some background, what is happening on the ground in Eswatini in relation to COVID-19. So Eswatini actually in Africa and Southern Africa is regarded as one of the countries with the strongest traditions, meaning we celebrate culture a lot. In fact, we have many events in the country where we celebrate our cultural activities and practices. Also some events, the king calls the people to come and celebrate in his household or the royal crawl. So as I said before, one event like that was held last year in December, even though there was a pandemic. The government tried to put all the measures for COVID-19 in during that event. And also, as I said before, that Eswatini is a religious country. Christianity is mostly practiced, and studies have shown that religious beliefs shape attitudes. They shape their risk perceptions, how people actually think about themselves as they are at risk or not. And also, it also shapes the health behavior of people. For example, how people will react during a pandemic will depend on how they believe, or which belief they are associated with. And also that beliefs in traditional medicine in Eswatini is very common, not uncommon. And actually the traditional medicine, which is our natural medicine before the Western medicine came, is actually recognized in the country's health system as the informal health system. So we have traditional healers actually who can render some of the care to people who believe in this type of medicine. In Taiwan and in also mainland China is referred to Chinese medicine, but in our culture we call it traditional medicine, but something like that, whereby it's African medicine. And Eswatini is a cohesive society, meaning we are close to each other because we do not actually have many tribes or different ethnicities. We are almost all same Black ethnicity. So that is also unique for us because it means we can visit people easily, we can have neighbors, we can talk to neighbors easily. We do not have a war, we've never had a war before. So we are almost a peaceful country. And also that we speak one common language, Swati, is almost Swati spoken everywhere in the country. And we have large clans. Clans are the people whereby we share the same surname. So we have many people like that, and we are most related to each other. Why am I mentioning this? I'm mentioning this because it will influence how, for example, we hold our gatherings during COVID-19, because we are a large family in Eswatini, and how we interact, it will be impacted by this pandemic. And Eswatini is facing multiple socio-economic challenges. For example, Eswatini, we have one of the highest HIV prevalence in the world among adults aged 15 to 49 years. About 27% of our population lives with HIV. And we know that HIV is associated with compromised immunity. So it means that these people might have low immunity, but at least a majority of them are on an antiretroviral drug, the HIV medication. And Eswatini has the second highest double burden of HIV and TB. So meaning people are living with both HIV and TB, about 70% of those, and is one of the highest in the world as well. And we also have a high burden of diabetes mellitus and a high burden of hypertension. I'm mentioning this again, ladies and gentlemen, because we know that in COVID-19 is associated with this. So these people who are suffering from these conditions, for example, we know that they are more likely to suffer severe symptoms of COVID-19. And besides that, Eswatini actually has low access to improved water. So only about 44% of the people in rural areas have a water tap or some running water or potable water or water that is improved or safe water to use. Most of the people actually are fetching the water from the river or from the spring. So this also can impact COVID-19 behaviors, because remember, hand washing is one of the most important preventive measures of COVID-19. So if only a minority of the people have running water, so it is also a serious concern. Also, about 63% of the population lives in poverty, under the poverty line, so they're living under $1 US dollar per day. About 60% of the whole population. Also, that will impact during the COVID-19 on how they get their food, for example, and also impact on, are they able to get the soap to wash their hands with, because remember, have to wash their hands with soap and water. So it will impact on those things as well. Also, the unemployment rate in Eswatini is about 28.1% in the whole population, and it's even higher among the youth. And that will also impact on how people can be able to afford to buy food, for example, and pay rent, for example, during the lockdown. Now, coming to the health system in Eswatini, it was severely impacted even before COVID-19, and it was worse even during COVID-19, because before COVID-19 arrived, we only have about 2 public health units with intensive care units, meaning high care, such as the one offering the, for example, the ventilators. So only 2 of those, and each one of them was holding about 6 beds, and the other one was holding about 10 beds for the whole country of 1 million people. So it really under-resourced. And also there was initially one hospital designated for COVID-19. So actually this hospital was being built and was operating as an outpatient department. But during COVID-19, it was changed to a full hospital with about 80 to 100 beds. And initially, that was a hospital that was taking care of COVID-19 patients. And however, this hospital was overwhelmed, and a new hospital was opened, but it was a makeshift hospital, meaning a temporary structure of a hospital where only cases which were asymptomatic were admitted, or without symptoms were admitted. And then there was shortage of equipment for PPE, for protective clothing. Also, we don't have a national health insurance, and also mental health services in Eswatini are not widely decentralized. They are located within the main region, Manzini region. So they are not well decentralized. And we have only 1 psychiatric hospital and only 1 psychiatrist in the whole country. So we are really under-resourced. And there are not very good referral systems from each level of the hospitals, as I will show you later. What happened during COVID-19 initially is that schools were closed, and schools remain closed even today. Ever since March 2020, there's been no schooling, except only for a few grades, like the highest grades. Like the last grade in high school was opened so that they can write the examinations. But largely, almost all the schools and universities were closed, and even today, they remain closed. There is some partial online learning that is taking place. And the borders were shut, and there were many things like businesses were stopped, and sports events were not occurring, and people lost their jobs, and the country is still on partial lockdown even today. And COVID-19 actually has, as you saw in the map, that some regions are more affected than others, so it also differs by urban and rural area. For example, the partial lockdown, it is not well applied in the rural area because of the people are living in very different places and very far from each other. So it's difficult to implement the lockdown in rural areas, but in towns, maybe it's possible. So there are those differences in the way the disease is affecting the country. In the rural area, also it's different in the urban area. So that was the background about Eswatini, ladies and gentlemen. Now I want to share the study that we did based on this background now, because we now have an idea how Eswatini is and what was the COVID-19 impact in Eswatini initially. So this first study is about the knowledge, attitudes, behaviors, and psychological distress among the general public during the COVID-19 pandemic in Eswatini. We conducted this study during the first wave of the pandemic, and the study was funded by this one. The study one was funded by the School of Medicine here at National Young Ming Tung University. So the reason why we did this study is that we noticed that during the first wave, the virus was still new And many people did not know about the virus, and also there was panic in the population. On social media, you could tell that people are panicking. Also, they were uncertain, not sure what will happen next, and if the pandemic was continuing to evolve and the cases were rising. And we thought that that could actually result in some people suffering from some psychological or mental problems. So that is why then we wanted to do this study. Because at that time, remember, there was no vaccine and there was no cure for COVID-19. So the anxiety, we thought that might be high in the population. But before our study, there was no study done on COVID-19 in Eswatini at all. We were the first study. Actually, one that was done before us was still ongoing when we were doing our study. It was also an online survey, but it was limited in the number of people who participated. And then also, we then said, let's do the study so that we can document during COVID-19 how people were reacting to the pandemic in terms of psychological and behavioral aspect. So the main objectives for this study was to describe the knowledge, the attitudes, the risk perceptions, behaviors, the myths. So myths and misconceptions are what people believe that might be wrong about a certain issue or disease. And also wanted to know what were the most needs of the people in Eswatini during COVID-19. And then we wanted to take these variables and we do associations between these variables to see if they are associated with each other. And also then we wanted to determine what was the prevalence of psychological distress, how many people were suffering from distress during the pandemic. And we then wanted to see which factors were predicting or associated with the psychological distress during the pandemic. The reasons for doing that, or the mechanism behind that, is that the health belief model and the protection motivation theory and the theory of planned behavior, they actually propose that health-related behaviors are largely determined by health-related knowledge, beliefs, and attitudes. So these theories say that behavior is determined by beliefs, knowledge, and attitude. That is why we have these variables for us to be able to associate. And also the protection theory further says that levels of perceived susceptibility. Susceptibility is when how people think that they can be at risk of getting a disease. And if they are sick, how severe they can be, or can fall, for example, can result in hospitalization, or they can just maybe be asymptomatic. So studies have shown that these people who think that maybe they have a high risk of contracting the disease, it will impact on how they are going to behave during the pandemic. Also, the social cognitive theory also proposes that a personal sense of control facilitates behavior change. What does this mean? This means that either how one will behave during a pandemic will depend how they think of themselves as able to prevent or avoid contracting the virus. For example, if I think that maybe I am unable to control myself, or my job, for example, is difficult in my job to be able to avoid COVID-19, it will affect how I'll behave on my job. That is what the theories and studies are showing. And also studies have shown that there are some demographic differences in the way people behave during a pandemic with respect to age, with respect to sex, education, race. And we have seen this in COVID-19, that the youth, for example, those who are young people, in Eswatini, for example, the youth, they were seen in town, going in town and moving around, some of them not wearing the mask, because we know that COVID-19 can affect the youth less than the adults. So maybe they thought that they were not much affected, so they changed their behavior. So we can see that already the studies that were saying this actually was also happening in Eswatini. So having said that, therefore, this is our conceptual framework. We wanted to see that does knowledge, attitude, and risk perception influence COVID-19 behaviors? And we then wanted to control for these variables which are identified in literature as associated with both the independent variable and our outcome variable. So we will adjust for these variables in the analysis, as you will see later on. And that was the first objective in the main analysis. The second analytic objective, we wanted to see if which of these factors identified from literature will actually be associated with the psychological or mental distress in Eswatini during the pandemic. So we wanted to see if these will be associated in Eswatini. And then what we did then, ladies and gentlemen, we did a study in Eswatini whereby our target was all the adults in Eswatini, meaning people aged 18 years and above. However, during that time, because it was lockdown, we cannot go to the household to conduct a household survey. So we thought about what could be the most possible way. So we thought about online, but however, online, people in Eswatini, some of them do not have internet access, or they are not on Facebook or WhatsApp or Twitter. So then we're like, maybe it's best to try and find out maybe telephone numbers. So we went to the country's telephone service provider. In fact, in Eswatini, we have one main telephone provider, which is owned by the government. So it has the highest number of telephone numbers in the country. So we went to that telephone directory or book to get the numbers of the households in Eswatini. And then in the households, then we're targeting adults who are 18 years and older, and asked them to complete some interviews. So this was a cross-sectional population-based telephone survey, and it was conducted in all the 4 regions I've shown you before in the country. And we used a 2-stage stratified random sampling and probability proportional to size. Let me show you how we did that. So we first calculated the sample size, and we found that we need only about 259 for a logistic regression at that time, because we were thinking that if we use a logistic regression, at least we will get the most rare cases, and when we multiply that, the effect size, so that it can be big. And we found that we only need about 259 people. However, because our main aim was to generalize to the whole population of the country, we wanted to increase our sample size to at least 1,000, because according to WHO, from 1,000 and above, and also in statistics, we know that from 1,000 and above, there is little change in the effect size of any research we are doing. So we targeted that. So we wanted this 1,000 to be distributed according to the country's population. So that is why you can see here that the distribution of the numbers in the different regions was by the proportion of the people in the country. So that is what we targeted in each region to sample for each region. However, because we are dealing with people, some people will refuse. Some household, we cannot find the people in the household, or some telephone numbers cannot pick up. So we wanted to increase our sample by 500 or 50%. In case some people don't respond, we can be able to replace them with other people. So in the IRB, or in the Institutional Review Board for Ethics, we asked that we enroll about 1,500 participants. However, we told them that we will stop at about 1,000. If we can be able to reach 1,000, we will stop. And our inclusion criteria for someone to be in the study, they have to be from a household that had a telephone from this company called Eswatini Post Telecommunication, and they had to have an adult in the household who was present at the time, or anyone else who's above 18 years in the household at that time, we will ask to participate. They have to be Swati, and they had to be more than 18 years, and they had to agree to participate. However, sometimes we found people who cannot speak Swati or English, so we did not include those people. And some people were too old, for example, in other households, too old to hear our questions, so we had to exclude those people. This is our flow diagram for the sampling. In total, from the booklet from the company for the telephone, we were able to locate about 18,000 households. However, we were able to call numbers, about 7,000 numbers that we called. However, about 6,000 of these numbers did not pick up, or were faulty, or were not active at the time. However, we were able to make about 1,120 telephone calls. And however, of these calls, about 69 of the people said they do not want to participate. About 30 of the households did not have adults at the time. So some people said that there's no adults in the home right now. However, some people were able to agree, but then when we're doing the calls, some people will drop out of the call because of the refusal or because of the network. So sometimes they drop off, about 18 of those. That's why these were excluded. And then in total, we were able to have a sample size of about 1,003 people whom we analyzed in the study. This is actually equivalent to a response rate of about 89.6%, which is really high. What did we use to conduct the data? During that time, remember COVID-19 in last year in April, there was no instrument for COVID-19. So we tried to look around in online. Luckily for us, we were able to find that some group in Europe, one group in Europe already they developed some instrument or tool for COVID-19. It is known as the WHO Tool for Behavioral Insights. It has many sections. And in that tool, we were able to ask some demographic information about sex and age and all those variables you saw before. And also we asked about the knowledge. There were about 19 questions about knowledge. And also we asked 4 items about attitudes. Also we asked about the risk perceptions, 2 items. There was one item for perceived self-efficacy. Self-efficacy, I said before, that is your ability to be able to avoid contracting COVID-19. And also we have about 13 items asking about the people's behavior, both protective behavior and risk behavior related to COVID-19. We will see later on. And also for the mental health status or psychological status, we used the Kessler 6-item scale for the psychological distress. It has about 6 items. It was developed in 2010 and has been widely used all over the world for measuring distress, especially during the pandemic. It has been widely used. And however, because it's the first time this instrument we're using in Eswatini, we had to subject it to cultural relevance or validation. So we submitted the instrument to some experts in behavioral science and mental health.
Hello, Mr. MDUDUZI, sorry again.
Hello.
Sorry for the inconvenience again.
No problem.
Just want to remind you again, to make
Slow
it
down.
slower, please.
Okay.
Thank you.
Okay.
And I'm sorry.
No problem. Don't feel sorry. It's okay. I understand. Thank you for that. So then what we did, we gave the instrument to some experts in Eswatini, and they validated the instrument, and then we pre-tested the instrument in 22 May and 28 May in 2020. Actually, I also made some of the calls from here in Taiwan to make the call so that I can see if the people in Eswatini are able to respond to the questionnaire. And we then also went to the directory telephone book. We got 10 numbers, 2 from each region. And then we tested the instrument among 10 households. What we discovered during the pre-test is that the instrument was a bit long because during this time, actually, it was taking about 20 to 25 minutes to complete. And some participants said that it is very long. So we had to change and make the questions very few, and we removed some questions. So eventually then we're able to ask and get clearance from the Eswatini Health and Human Research Review Board, who gave us a quick ethical review, and we're able to do the study. So the study was conducted between 9 June and 18 July 2020. You can see this graph here. We have the number of cases in the country, and the line that is orange is the deaths. And this blue line is the number of COVID-19 cases. It is cumulative, it's rising up, as you know that there are cumulative cases for COVID-19. You can see that at this time when we did the study, there were about 840 cases at that time. But by the time we had already finished, there were about 2,000 cases, so it was rising up, and about 11 deaths at that time were there in the population. So this gives you a big picture of at what time did we do this study. So it was an early phase. We are hoping that if we have money, we can do the study again now to see if the behaviors will be changed. Because actually when we applied for ethical clearance, we said that we have the study as a panel study, meaning again, we have follow-up at some point in time, but we don't have the funds right now to do that. So each interview took about 15 minutes. So in the study on average, and we had about 7 data collectors or research assistants who were asking these questions in English or Siswati. So we were able to train them on the instrument, and we trained them on ethical clearance, and we trained them for about 2 hours on the Zoom about how to conduct interviews. And also we gave them some role play on how they can conduct the interviews over the telephone, because most of them, it was their first time to do the telephone interview. For analysis, we use data version 15, and we produce some demographic descriptive statistics. And for the behaviors, because it's a continuous variable outcome, we use linear regression. And for the psychological distress, we use modified Poisson regression with robust standard error. As you know, some of you maybe will be surprised why we use Poisson regression, because logistic regression is the commonly used one for binary outcome, whereby you have a yes or no answer, or an outcome with two categories. However, in our case, we found that actually our outcome variable, the psychological distress, was very high in Eswatini. And if we use the odds ratio, it will mean that we are going to overestimate the magnitude of the problem or the measure of association in the country. So we then have to use this modified regression, Poisson regression, because what it does, it narrows the confidence interval and gives a precise estimate of the magnitude in the country. Also, the good thing about modified Poisson regression is that it is actually also able to give the direct or estimate the relative risk directly. So we can tell the risk in the population directly from a Poisson regression. That is why we use the Poisson regression. And then we made sure that all the statistical analysis was significant at the value of less than 0.05. Our results, first I will describe the demographic characteristics of the population. We can see from this table that a majority of the participants were aged 25 to 60 years. We will call these ones the working population, because in many countries, this is the working population. People who have some job or formal job in government, for example, or companies. And we can see a majority where 72% were female, and a majority were having some high school or secondary education, followed by tertiary. And we can see that about majority of them did not have any health training, or they were not working in any health industry. So they were not essential health worker. So only about 9% of these were healthcare workers. And we can see here that a majority were urban people, even though, remember before I said that many people are rural. So it means because of the telephone number, they are mostly in the urban area. So that is why we see here that we have more people from the urban who participated. And as I said before, that many people in Eswatini are Christian. So we can see here that we have about 98% of the people being Christian. I hope I'm now slow enough, Reski. Let me know if I'm still fast.
Yeah, you can make it slower.
Okay, thank you. And then we also asked the participants to classify themselves. We asked them, for example, in your neighborhood or in your community, can you tell us, do you think you are rich, or you are poor, or you are in the middle class? So these variables, they self-classify themselves. So many of them said that they are actually, they think that they are actually in the middle class in terms of wealth index. And we asked them, how many people do you know who have COVID-19? Most of the people said that they do not know anyone at the time who had COVID-19. Remember, this was the beginning of the pandemic, so that's why many people did not know anyone with COVID-19. And also we asked them, do you feel well informed about COVID-19? A majority of them said yes, they felt well informed about COVID-19, but some said they are not. And a majority of them were from this region, because remember, we did the proportional to size. So yes, we get more people from this region. And also there are more people in this region in the country. And we only found that about, on average, 3 out of 4 people would be having masks at the time. And the median age for household was 5 people per household. Now, when we asked them to say, what is your major source of information? So we wanted to know, where do people get their information about COVID-19? We can see from this graph that a majority of the people said that they get information from TV or television, about 40%. And about 30% said they get information from the radio. So these were the 2 major sources of COVID-19 at the time. And we also asked participants, has anyone in your family or yourself, have you lost a job or have you lost some business during COVID-19? And only 35% said yes. Some family member or myself, I've lost a job because of COVID-19. And remember, we wanted to know what is their beliefs and misconception or myths about COVID-19. Remember, I told you before that many people in Eswatini, they believe in traditional medicine. So you can see here that even though many people believe in that, but you can see here that about 50% did not believe in this medicine, and 15.8% said that, yes, they believe that this medicine can cure COVID-19. Remember, at the time, there was no cure for COVID-19, so people were believing that maybe our local or Eswatini medicine can cure. Also, remember, Eswatini is a Christian country, so we wanted to know if people believe that COVID-19 can be cured by praying. So about 65% said, yes, we believe prayer can cure COVID-19. Also, we asked them, do you believe home remedies can cure COVID-19? Home remedies are when you in your home, for example, you can take lemon, or you can take orange juice, or you can take ginger, or you can take garlic. So that is kind of concoction or a mixture of those things. Some people were preparing that mixture. And then we asked them, do you think that mixture can cure COVID-19? About 39% said, yes, we think the mixture from my household can cure COVID-19. And I must say to you, ladies and gentlemen, that during this time in Southern Africa, one country called Madagascar is a country in Southern Africa, an island. Actually, one of the scientists, they discovered some remedy from their country in a lab. It was called mhlonyane, so also called Madagascar concoction. So this mixture was well advertised in Africa, and many countries, actually governments, they order this concoction from this country. And many people were pressuring or putting pressure on the government in Eswatini to order this particular concoction. So we wanted to know how many of the people in the country believe that this particular mixture can cure COVID-19. We found that about 17% of the people in the study said yes, they believe that this concoction can cure COVID-19. Even though WHO and all other organizations, they say that there is no cure for COVID-19, but people believe that this one can cure. And remember also, some countries like in Eswatini, during the start of COVID-19, people were having many theories to say, where is this coming from? So we wanted to know, what do they believe is the cause for COVID-19? Many people said that because they are Christian, they said that they believe that this is because now it is the end of the world. It is the end of times. That is why we are seeing COVID-19. Some people said that is because some people made it up in a laboratory in China, for example, to wipe out African population. So they thought that it is a weapon to wipe out the African population. About 15% of those people believe that. Remember again, we wanted to know what is the most critical need of the people in Eswatini during the partial lockdown. We asked them to tell us which is the highest need you have in your household. And most people, about more than half, said that they have serious need for food. Because remember, I told you before that many people live below the poverty line. They are from poor household. That is why this was not surprising. Also because many shops were closed and businesses were closed, and many people have lost jobs. We also asked them their other needs. They said money, about 20% they needed money, and only about 7% said that they need medication during the partial lockdown. We also wanted to know how much risk do people think they have towards COVID-19? So we asked them, what do you think is your probability of contracting COVID-19 or getting COVID-19? We can see from this graph that nearly half of the participants, they said that they think their probability of getting COVID-19 is very high or high. So many people think that they will get COVID-19. And we also wanted to know, do they think if they can get sick, they can be severely sick or not? Meaning they can go to hospital or even die. We can see from this graph that equal proportion, about 30%, said that they think that if they can get COVID-19, they can be very severely sick. However, some also equal number said, no, we cannot be severely sick. So it was equal split on these numbers. And remember, we have wanted to know the knowledge about the participant, how much knowledgeable they were about COVID-19. So we asked a lot of questions about COVID-19 symptoms and also about the knowledge about COVID-19 preventive behaviors and in general. You can see here that if you look at the first 3 rows, 82%, 70%, 50%, they almost know that COVID-19 is caused by fever, dry cough, and shortness of breath. However, people did not know much about the other symptoms of COVID-19. Why did we ask this question? Is because at that time, remember, it was important for someone to know if they have COVID-19 symptoms because they have to report to the Minister of Health so that they can be able to be tested. So we wanted to know how many people know the symptoms. So that's why we were surprised if many didn't know about the symptoms. And then also we wanted to know, did they know the incubation period? So we can see here that actually the knowledge about incubation period, about the cause of the virus, also about if there was a cure or not, it was very high. And this is surprising. Look at this. What causes COVID-19? So many people know that COVID-19 is caused by coronavirus, but still when you ask about belief, it's a different answer. They say they believe it's caused by other things. So it was surprising. And then we also wanted them to know what is their attitude towards COVID-19. So wanted to know, are you worried about COVID-19? About 90% said yes, we are worried about COVID-19. We asked them if a COVID-19 vaccine can be available, because at the time, remember, there was no vaccine. So if a vaccine can be available, can you take it? A majority said yes, they were willing to take a COVID-19, about 77%. And we asked them, are you afraid of COVID-19? About 74% said yes, they are afraid of COVID-19. And we asked participants, do you believe that washing your hands with running water and soap can actually stop the transmission of COVID-19? Almost 91% said yes, they believe that washing hands can prevent COVID-19. Now, coming to asking participants, now we ask them how difficult or easy it is for you to avoid contracting COVID-19. You can see from here that a majority of them said that it was very difficult for them to avoid COVID-19. So it can tell us that maybe they think that the measures are very difficult to observe. So many of them said it's difficult to avoid contracting COVID. And now coming to the behaviors themselves, we wanted to know if people were adhering to the WHO and also the country preventive measures the government has put in place. We asked participants, do you wash your hands for at least 20 seconds? About 67% said yes, they wash their hands for 30 seconds. We can see also that some people were using sanitizer or sanitize their hands during COVID-19, majority, and also that some people were covering their mouth when they were coughing, for example. Also, however, about 97% were wearing masks in public, and also majority, they said they were able to do physical distancing, meaning the social distancing, only 62%. This is very low though, because remember at the time it was the main preventive measure and it was a partial lockdown, but still people, only 62% were able to social distance. And actually we asked participants if they were able to disinfect tables, the chair before they sit. About 46% said yes. And also we wanted to know, because remember it was a lockdown, so we wanted to know how many people are visiting their friends or have visited their friends or family or members of neighbors during this time. about 26% said they visited their friends, even though it's a partial lockdown. Now, remember there was that conceptual framework I showed you that we wanted to know if knowledge, if attitude, if risk perception is going to be associated with the behavior. Here, the higher the score of the behavior, the more protective or the more safe the behavior is. So here what we are seeing is that for the crude model is when you have only knowledge and behavior alone, the two variables only. So this is linear regression. So it's adjusted in this side, we adjusted for these variables, the confounders at the bottom. And here it is not adjusted, it is simply the two variables together. So this is linear regression. So here what we can see is that the higher the score of the knowledge, meaning the more someone was knowledgeable, also the higher their score for behavior, meaning the more protective, the more safe their behavior was. And this is significant if you control for all these variables. I mean, sorry, before you control for variables. And however, once we control for these variables, you can see that knowledge in the final model, also in the model one, they are not significant. And also for attitudes, the higher the score of attitude, the more positive the attitude is towards COVID-19, meaning the more people are truthful or they believe in the right thing about COVID-19. So we can see here that the higher the score for attitude or the more positive the attitude, the higher the protective the behavior. So meaning people who have a positive attitudes towards COVID-19, also, even if you control for these variables, they also have a higher score of practice, meaning they have safer behaviors. And now, remember, I wanted to know if people think it's difficult or easy to contract COVID-19 or to get COVID-19. We can see here that those people who said that they think that it is difficult to avoid COVID-19, actually, those people, they were less likely or they have a low score of behavior, meaning they were not practicing the safe measures because they thought it is difficult. So it makes some intuition or it's intuitive or it is translating to that sense to say that those who think that it's difficult, therefore, were unable to observe all the preventive measures. And then coming to the psychological distress or mental distress, we can see here that we wanted to know from the participants how many of them were distressed. We can see that about 8% of the participants were classified to be having severe, serious or mental distress, and about 42% had moderate distress. If you combine these two variables, you can see about 49 or 50%, actually equal numbers, had the mental distress disorder, some mental distress or mental disorder or problem at the time. So here is almost equal numbers. That is why we used Pearson regression to determine which factors are actually associated with psychological distress. So in this table, we show you the crude association, meaning one by one, and also we show you the adjusted, meaning if you control for the other variables in the model, is then association between these variables and the outcome variable, which is psychological distress. I will focus on the adjusted model because it's the final result that we'll report. We see here that the youth actually had a higher risk of being psychologically distressed. So about 1.06 times more distress among the youth compared to the working population. We can also see here that if you are married or you are living with someone as if married, you had a higher risk of having some psychological distress compared to someone who was single or not married. Also, if you live in the region where the capital city is located in the whole region, remember, this is the region where now that has the highest number of COVID-19 infection. We see that if you live in this region, these people actually, there was a higher risk of psychological distress from these people in this region compared to the people in the Lubombo region, if you adjust for the other variables in the model. And also the Manzing region, also the second highest infected region, you can see that also there was a higher risk or increased risk of having psychological distress compared to the Lubombo region. Also, those people who said that they are not well informed about COVID-19, they had a higher risk of psychological distress compared to those who said that they are well informed with COVID-19. And also we can see here that those people who said that they have received from the government some financial assistance, or the government has given them some money during COVID-19, they were also the ones who said that they have more psychological distress than those who did not, which was surprising, because you would think that if you got some government assistance, you have less distress. But some studies actually show that these people, the reason why in the first place the government is giving them this assistance is because they are having some difficulty during the situation. So which is why maybe in this case, you can see that the association might be the other way around, it's possible. Also, we asked people if they felt lonely or not lonely. Those who said they feel lonely, they were also more likely to experience psychological distress. And those people who said that they are worried about COVID-19 such that they cannot sleep at night, they also have a higher or increased risk of having psychological distress or to be having some mental problem during the COVID-19. And lastly, we wanted to know how many people were considering killing themselves or committing suicide during the COVID-19. We can see here that about 1.7%, nearly 2% of the population, of the participant, they think or thought about killing themselves because of the pandemic, which is a high number. So recommendations, we recommended these results to the Ministry of Health. We submitted the results to the Ministry of Health, that they should also provide some education to the public in order for us to be able to correct the misconceptions. Also, for the Ministry of Health to strengthen the behavior change. For example, they should be able to deploy more police to monitor people's movement during the lockdown. Also, that there is a need for the ministry to provide mental health services to the population, because at this time, many people were feeling distress. Also, that the Ministry of Health must also help us to replicate this study, because at that time, remember, we only had people from telephone number, not cell phone number. So we were interested to say, can they give us some fund to repeat the study after maybe, they say after a year, to repeat the study is also a recommendation. Also, there is a need for qualitative study to investigate why people have these beliefs and misconceptions and why people are having mental distress during the pandemic. So some few strands, this was actually the first study in Eswatini to use telephone-based survey. Before it has never been done, so we were able to provide some new insight if it's possible or not to conduct such a study. And we tried to implement proportional sampling to size so that we can actually be able to generalize the findings. In fact, in the journal paper that we are submitting, we have already applied sample weights so that we can generalize to even a higher population. But this study also has some limitation. Some people may answer favorably for some reason. Also, selection bias is possible because of the sampling using telephones. Also, some people may forget their behavior before, so recall bias. And also our findings are limited only to people with telephone landlines, because in this result I presented, we did not do weighting. Otherwise, with that, there are many people to thank, but I would like to thank you, moderator, for your time and for the participants for being attentive, and I apologize for being fast when I speak. I hope you got something from my presentation. Thank you so much.
All right. Thank you so much for Mr. Mdu. I can see and we can feel also, like all the participants can see your you and your team do really hard work in conducting your research, and we can see such a complicated, challenging, and of course very useful studies. And again, we would like to say thank you so much for your informative, and it was very interesting. And I believe all of the participants and attendees also can get a lot of insights and knowledge regarding especially for the research methods, right? Okay, so very well, ladies and gentlemen. Now we move to the question and answer session. So we have 15 minutes for this session. So for everyone who has questions, so you can directly ask Mr. MDUDUZI on the Zoom, or you can speak also in Indonesia if you want, and I will translate it for Mr. MDUDUZI. So please everyone, any question? Ada pertanyaan? Silahkan. Sorry, you can raise your hand if you have any question. So yeah, Nurse Ihsan, I think he want to ask something. Please, you can wait a minute.
Okay. Can you hear me?
Yeah, I can hear you very well.
Right, thank you.
Mr. Ihsan, yeah, time is yours.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you for the opportunity. I would like to ask Mr. MDUDUZI directly. Introducing me, Ihsan, student professional program nurse, Faculty of Public Health, Universitas Muslim Indonesia. My question is, what are the recommendations for us nursing students in Indonesia to help the community in dealing with the COVID-19 pandemic situation? Because in my area, there are still many people who don't apply the COVID-19 protocol. For example, not wearing masks, not keeping their distance, and many who don't want vaccines, and many people don't want advice, and many other problems and causes pandemic to be left unresolved. As nursing students, what role can we take to help overcome the COVID-19 pandemic in Makassar, Indonesia? Thank you very much.
Sorry, can you get the question, Mr. Mdu?
Yes, I got the question. We can take 3 questions at a time.
Okay.
Yes, we can take the next 2 questions,
so
and then I can respond after 3 questions. So let's take 3,
right.
respond 3.
Okay. All right then. So we open for 3 questions. So we already have 1 question. So now another 2 questions. So please, anyone, if you want to ask, please raise your hand on the Zoom. Eza Kemal Firdaus. Yeah. So Eza Kemal Firdaus, please.
Yeah. Before of that, please introduce myself. My name is Eza Kemal Firdaus, as lecturer of nursing faculty, Muslim Indonesia of University. So you explain about many impact because COVID-19, and one of that is psychological distress. So my question is, what the best strategies, framework, or solution in your university, ST1 University, to handle for this problem? Thank you.
Okay, thank you. We can move on to the next one, Reski.
Sorry. Okay, yeah. Thank you so much, Eza, for your question. So the next one, okay, Ibu Andi Asrina, FKM. please.
Thank you,
Ibu
moderator.
Andesrina.
Okay, thank you. I hope my voice will be heard clearly. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you, Rizky and Mr. Jujuzi. Very interesting discussion and very interested in discussing COVID-19. From some literature that I read about the mortality rate to COVID-19 in Africa was lower than what WHO predicted before this case spread throughout in the world. I will asking for Mr. Duduzi, do you think what causes this is Africa used to disease outbreak so that the government and society respond more? Quickly or have low community mobilization, or is there an early detection method? I think this is important for me, general for our people in Indonesia to reduce the spread of COVID-19. Can you understand about my?
Yes, very, very well.
Okay, thank you.
All right, thank you so much, Ibu Andesrina, for your questions. And I think for the first session, for the Q&A session, I think 3 questions, that's enough. And we will give time for Mr. Presenter probably to answer the questions.
Okay, thank you so much, Reski, and thank you so much to the people who asked or the participants who asked the questions. All these 3 questions are really wonderful questions, and I would like to start to respond with the first question. The first question was that what can be done by the nursing students in Indonesia to help with people to change their behavior, or even themselves to change their behavior regarding COVID-19? Well, I should say that maybe as a disclaimer, I am not an infectious disease expert, but I am more of a socio-behavioral aspect expertise. So I will comment on the socio-behavioral aspect of why people are doing what they are doing. So I think as nursing students, I don't know what's happening in your country, but you shared something like some people don't wear the mask. Also in my country, in Eswatini, that is the same situation that we have been seeing. So because for me, I was not in Eswatini at the time since COVID-19 started, because there were no flights to go back home, but I was able to do the study because I have some colleagues back home. So I had to write the protocol, and then I had to ask them to supervise the data collected at home. So I think the main problem with the behavior of people during the pandemic is that in general, it is difficult and it takes long for people to change their behavior. That is what behavioral theories have taught us, that behavior change takes a long time. Unfortunately, when COVID-19 began, people had to change their behavior within a short time. So it caused some people not to react in a positive way or take some time to adapt. I think even in Indonesia, even though I don't know, maybe as time went by, some people were much more wearing masks than maybe initially. I don't know the situation in your country, but in our country, in Eswatini, the culture of wearing masks was not there at all before COVID-19. Unlike in Taiwan, where people were wearing masks even before COVID-19. So we learned this culture only during COVID-19, but it took some time, some police reinforcement. So as nursing students, I think you guys can, first of all, start with you to model the behavior. Be the ones who are seen by the people to wear the mask. Also give knowledge or educate the people about the benefits of the mask. Educate people about the COVID-19. Give some education to the people, because most of the time in the society, people have some misconception. So it helps to give some education to remove those misconceptions. Also, you can also participate with colleagues and also your lecturers or advisor to suggest some research topics you can do, because for you to know why people do not wear the mask, for example, you need to have the evidence. What is the reason? It's a qualitative study. Why do people don't wear the mask? So that you can then sit down and use that evidence to say, oh, okay, people do not wear mask because they say mask have 1, 2, 3, 4, 5 to them. So how can we best assist them? So you can also participate in research as nursing students with your supervisor, suggest some research with your colleagues on how you can find out the answers. Why people in Indonesia, for example, they have some difficulty to wear the mask, for example. So there are many other measures you can participate, but mainly for you as a nursing student would be that you model the behavior, you educate the people, and also you participate in research and you educate people. And on social media, you are the one who's promoting science. Do not be the one who's questioning science. If you are a nursing student, you have questions about COVID-19, you know you have to go and search the journal paper, the WHO, CDC, the website, the government website, where to get COVID-19 so that you can share the correct information to the general public to avoid the misconception. Then the question number 2 was, what is the best solution to handle the distress that is caused by COVID-19? You asked in my university and in Taiwan, for example. Well, in Taiwan, there wasn't much because in Taiwan, the cases are very few, less than 1,000. So but what they did also in Taiwan, I started with Taiwan, our universities, at the beginning of the COVID-19, they have some information to share with students on where to get help, which number to call if they have any issue or psychological distress about COVID-19 or about not going home. So even the government of Taiwan also have a helpline where people can call if they have any questions. So also they refer people to the nearest hospitals to call the people who are mental health experts. So there was that kind of arrangement. But in my country, in Eswatini, I would be honest and say that did not happen so obviously, meaning people did not know actually where to go and get help. Because as I said in my presentation, we do not have, even though we have some mental health experts, but only one hospital is dedicated to mental health issues. And also in the country in Eswatini, actually, there is no health policy on a mental health policy for mental health. So the coordination of services in Eswatini is not decentralized. So the solution during this kind of time for the population, it will be that as a country, when there's a pandemic, the government needs to decentralize the services, the mental health service. For example, if before you have only about 10 centers that offer, or hospitals that offer mental health, during the pandemic, you must maybe double the number or increase the number. Also have some helpline for the country where people, they can call in and talk about their problems. Also, you should empower more people who are trained like nurses or nursing students or some people who are working in psychology, empower them more during this time, give some training about the disease, the new disease, so that they can be able to talk to people about this pandemic, give them information. So I think that can really go a long way to help reduce the stress in the population. Also, the one last thing that we must not forget is the media, the journalists. We should also educate the journalists how to report the news to the people. Because in my country, what I saw was that most of the time, the journalists, because they want to sell their newspaper, they would give out more the negative news, the bad news about COVID-19. But actually, they don't report more of the positive news, like how many people recover from COVID-19, or what are the good things about, for example, what's the good knowledge about COVID-19. But always the headline is about the bad thing, who died from COVID-19, and all those bad news. So I think maybe also as a country, Ministry of Health, we need to also educate the media on how to report on COVID-19 to avoid the stress. And lastly, also educate the family member of the person with COVID-19, so that they do not have to tell them the best things, or they don't. For example, if someone is sick with COVID-19, they must not have them social media. They must tell them, don't go to social media, focus on your illness, so that they don't get this negative news and bad news, which can also make them to suffer from the illness even worse. I hope that answers your question. And then also one brilliant question was the last question on why Africa actually has now, seems like Africa has now a lower fatality rate than it was initially projected. Actually, that question has been lingering in our minds as well initially. Why? That's a very good question. And in the first wave, many people, I must tell you that many people in Africa actually were celebrating when they see that the COVID-19 cases in Europe are very high, in Asia very high, but in Africa, seemingly only Egypt was having a case. So they were like, yay, African people are resistant to COVID-19. African people have some genetic or DNA is resistant. Unfortunately, at that time, that was the time when we were supposed to prepare for the pandemic, because definitely it was coming our way, but it was coming slow. So I will explain why I think it was low. One, it was low to come to Africa because in Africa generally, we do not have major transportation industry. Like for example, some countries do not even have the airline for the country, or they have only one airline. So people don't travel much by air. Only business people maybe travel by air much. So that means what? That means that the rate of the travel of the pandemic was lower than other countries during the first wave. That's why it came late. Also, the reason why Africa seems to be less affected, we have experience with Ebola before. So maybe there were some structures that were already in place, some systems that were already in place for other pandemics before, like Ebola in West Africa. Maybe they already know how to plan for this kind of illness. For example, let me make an example. You see Taiwan did very well, mainly because they have a previous experience with SARS. So by the time they started, they're already alert. So maybe some thinking is that maybe in Africa, also that happens. Also Africa, besides Ebola, like Southern Africa, we have more of the PEPFAR or the US government funded projects. They already have in place, like the Doctors Without Borders already have in place some systems on how to tackle issues at community level up to country level. So there are those kind of systems and I know in Eswatini, in one region, they already integrate COVID-19 with some of the Doctors Without Borders project. So yes, maybe that's also have an effect, but we did not do a study yet to determine really what is the issue going on, but it's just my informed guess or speculation. Also in Africa, if you can look at the African population, before I end with the last question, look at the population for Africa, you will see that we have very few elderly people. Most of our population, like in Eswatini, we are very young, 22 years. So very young population. So we know that COVID-19 has more effect on all elderly people. But look at the United States, look at other countries, UK, whereby they have many elderly people in the nursing homes. In Africa, we have very few nursing homes. So the effect of the virus is less in Africa because our population is fairly young. So therefore, they can fight off the pandemic. In some cases, that is the case. And also some people were already on some drugs, like antiviral drugs, like HIV drugs. So maybe there already some protection. We don't know yet, but we're thinking maybe some protection from antiviral, from the many immunization programs in Africa and many other structures like people are on treatment. So maybe also it gives them some resistance from the pandemic. We don't know. We have to do that research right now, but it is my informative guess. Thank you so much, moderator.
All right, thank you so much for your questions, and I hope all the one who asked the question can get benefits of the question from the speaker. So we still have one. Sorry. All right. So we still have one topic that guest speaker, Mr. MDUDUZI, want to share to us. So before the first presentation is talk about the social behavioral and mental health impact of the COVID-19 among the general people, and now he would like to talk specifically about the COVID-19 related vaccine, acceptance, willingness to work
Kalau ada tamu
practical
sebentar,
distress
tahu tadi.
and preparedness among healthcare workers in Eswatini, an online nationwide survey. But before we jump to the next topic, Mr. MDUDUZI, probably we can take a 3 minutes break. So you can do some stretching and also, or you can take a drink, and also all the participants also can take some drinks after hear the very wonderful studies and result from Mr. MDUDUZI. So we will have 3 minutes pause for this international guest lecture. Thank you so much.
Thank you.
All right. So, jadi kita bisa istirahat dulu untuk 3 menit, Bapak dan Ibu. Dan insya Allah setelah 3 menit, kita akan kembali melanjutkan persentase dari Mr. MDUDUZI terkait dengan efek dari COVID, lebih fokus kepada professional health. Ya. Oke, terima kasih. Alright. I think, Assalamualaikum warahmatullahi wabarakatuh. I hope all the attendees, all the participants are still here. Alright, Mr. MDUDUZI.
Hello.
Hello, all right. So I think it's already 3 minutes, and I think that's enough for stretching or to take water, to take some refreshment. And I think we can move to the second topic about the COVID-19 related vaccine acceptance, willingness to work, burnout, psychological distress, and preparedness among healthcare workers in Eswatini, an online nationwide survey. So, without further ado, time is yours, Mr. MDUDUZI.
Thank you so much, moderator. You can still hear me, right?
Yeah, very well.
Yes. During the break, I was trying to get some light because I did not know that this room is not actually having much light. So I apologize for the poor lighting on my side. Yes. So thank you so much once again for all the questions and for still being here from my last talk. So now this is the last talk for today. After we had done the study on the general population, now there was a time whereby, as I said before, that the first wave was going down and everything looked like, oh, now it's normal, we can go back to normal. But what happened is I anticipated, I thought about what can happen if there can be a second wave. How prepared are our healthcare workers and the facilities to manage COVID-19 in a second wave? And also I was anticipating based on literature that there will be some vaccines maybe soon. So I wanted to know if the healthcare workers will be able to accept the vaccine or not, because we know already from the population that maybe they are willing to accept the vaccine. So this is why then I did this study. Secondly, I wanted to know how the healthcare workers are feeling in terms of, are they feeling burnout or tired from this particular pandemic? And also how are they mentally distressed? Are they mentally distressed or not? Remember, this population, however, is healthcare workers. So they are very busy, and this was a very busy time. So the best way was that maybe let us do an online survey instead of telephones, because we did not have the telephones. And even if you use telephones, healthcare workers are very busy, you cannot find them at work. In the house. So the best way was to do online, because at least in Eswatini, the healthcare worker, they have some WhatsApp group, some Facebook page where they are all together. So it is possible to do this kind of study. Also, some facilities have the page for Facebook or WhatsApp page for, group for all the workers. So I thought maybe it's possible to do this study. So one lesson that I learned from COVID-19, because I started doing research in 2008, and I know at that time when you go online and you search for online survey, it was very rare to find people using the internet to do research. Even if they do the research online, many reviewers or many commentators would question, how credible is the method for online? How can it be sure that? So they were not mainly accepted, but one positive thing from COVID-19 that I noticed is that it changed the way we do research. So I did not want to be left out from that experience, and also in Eswatini to contribute to see how can we do internet research in Eswatini. So I was happy that during this time, this method of collecting data is now acceptable. So ladies and gentlemen, let me share with you then the findings from this study. Before I share the findings though, I won't go back to the background because I have already given you a background about Eswatini. I just want to focus now on the health system only briefly, and then I tell you the results. So in this study, maybe before I share about the findings, I just want to show you how the healthcare system in Eswatini is organized. So in Eswatini, we have about 5 levels, and sometimes we group them into 3 categories. So we have the community level facility. In fact, these are not facilities per se, but we have what we call community health workers, who are known as rural health motivators. These people are like your mother or your grandmother who volunteers to say, I can volunteer my service to help anyone who is sick in my community. So they don't have any training in health. Instead, what they do, they just teach them how to help people to be referred to the nearest facility. So they are mainly your grandmother and your mother or your sister. Mainly women. I am yet to see males, but I think maybe there are 1 or 2 males nowadays, but mainly it's been women. And it's an old project, that this one. So we have that level. And then we have from the Ministry of Health, also we have the first level, which is under primary care, whereby we have clinics, what is known as district clinics in other places, the primary healthcare facility that offers limited service. Here, there's no admission of patients. So there's no inpatient, all of them is outpatient. And most of them, they provide preventive and some limited cure for diseases or treatment, and then also some public health measures or health education or programs is given in this particular level. And then we have the health centers. Just before the main hospitals, we have what we call health centers. They have some inpatient or admissions, but limited. So they have limited maternity or delivery unit, limited ward to admit sick patients. And then they have all this curative for the public health unit, but they are smaller than a hospital. And then we have about regional hospitals. We have about 7 regional hospitals actually. 2 of them are owned by religious organizations or faith-based organizations, and the government has about 4 of these facilities that are owned by the government. And then we have a national referral hospital, 1 referral hospital, and some 2 specialized hospitals, the one for mental health and another one for tuberculosis, for TB. So basically, those are the hospitals that we have in Eswatini, and this is how the system is structured. So for this study, the healthcare workers who were interviewed, who were asked to fill the questionnaire are those from here, from this level 2 upwards, and both in private and public sectors. So it's from here. So we did not interview or ask anyone here to fill the questionnaire from this level. So we were asking only professionals. So what happened during COVID-19 regarding to the response is that, as I said before, the government responded to the COVID-19 by making a makeshift hospital. This picture you see here was actually a big hall before, or a big building or a house before. But the government did this partition, divide some section. These are beds. This is the bed for COVID-19 beds. For those people who are initially said that they will be asymptomatic or no symptoms, but they still test positive for COVID-19. But later, this facility actually ended up admitting even very sick patients, even though it is only just makeshift or temporary structure. Otherwise, the government was able to mobilize resources, some donors, funding. Also, some health workers were redeployed to other hospitals. Many graduate nurses were hired during this time because the government, since 2017, has stopped hiring nurses and any professionals because of financial resources. But during COVID-19, all the nurses who were staying at home, who were graduates, they all got jobs in this time. And also the employers said that healthcare workers cannot go on leave, and the government tried to have some wellness units. Wellness units are the units whereby the healthcare workers can go to if they feel sick. So some office within the facility where the only healthcare workers can go and see some health worker if they're getting sick. But they were very limited, like only 1 per facility and only 1 person assigned. So basically this is how the government responded and also now they've promised to procure some vaccinations for the population, and the healthcare workers are going to be the first ones to be vaccinated. We were supposed to receive a vaccine about a week ago, but it did not come. The government has promised that maybe within the next 2 weeks, we are still going to get a vaccine. So right now in Eswatini, there's no vaccination that has taken place, even though our neighbor, South Africa, has already started vaccinating their healthcare workers. But for us, nothing has happened. And then this is one of the hospitals that was designated or was assigned for COVID-19 patients. So what happened is that there were many challenges that the healthcare system faced. For example, there was an increase in the number of infections among healthcare workers. And also people did not adhere to the preventive measures of COVID-19. Also, there was an increase in the number of people with COVID-19, but who did not have symptoms. Therefore, it meant that the hospitals were going to be full. So it's a challenge. Also, the country during the second wave, it ran out of oxygen for the whole country. There was no oxygen in the hospitals. Many people died because the hospitals did not have oxygen. Some people were dying at home, some were dying in hospitals. So it was a very bad situation during December, January. And there are a lot of drug shortages in the country. But the government in January was able to install one plant for oxygen in this hospital. So at least the situation then improved afterwards. And then also now we are also asking ourselves if we are going to have a third wave now during the coming April, May, June, July, because it will be winter in Eswatini. We are projecting that there might be a third wave, especially because we do not have a vaccine in Eswatini right now. So we are afraid that maybe a third wave is coming. And I'm already thinking about another study I can do again during this third wave, because we must do research until the COVID-19 is over, because we need to get data to inform the Ministry of Health. And also there are some new strains or new mutations of COVID-19, of coronavirus that took place in South Africa. And because, remember I told you before that we are inside South Africa, we are surrounded by South Africa. So whatever happens in South Africa, it affects us directly. So I think some of you have seen the news that there was what we call South African strain, or a strain of COVID-19 from South Africa. So the severe strain, we think also is the one that actually caused the many deaths in Eswatini during the second wave. So these pictures just show the government of Taiwan, for example, donating materials to Eswatini, and the US government donating as well, because Eswatini was having severe shortage of PPE during this time. Hello?
Can you hear me? Sorry.
Yes, I can hear you.
I'm sorry for the inconvenience. Okay. All right. And so for this section, so probably we can make it 30 minutes or 35 to 40 minutes for this topic.
No problem. Okay, thank you.
All right. Thank you so much.
All right, thank you. Thank you. Yes, and then thank you for that, moderator. And then also in summary here, still the challenges, I've already mentioned them. And there were some news that healthcare workers were running away from patients in the first wave when they first learned about the COVID-19. So that is why then I wanted to do this study, because some healthcare workers also go on strike because there was no protective equipment. Also, the government did not compensate them for the working extra hour during the COVID-19. So right now, about in end of January, we had about 3% of the healthcare workers infected with COVID-19. So about 500 healthcare workers, excuse me. So then you're asking yourself, then what is the reason why we wanted to do this study? We do this study because we thought that healthcare workers are severely affected by COVID-19 because they are on the front line. So we want to know now, how are they experiencing the COVID wave, the second wave, and how are they doing mentally? So that's why we did this study. And at this time, there was no study done in Eswatini among healthcare workers on COVID-19. So with this study, we wanted to determine the willingness of healthcare workers to get vaccinated and to assess if they're able to continue working during this pandemic. And also we wanted to describe the burnout of the healthcare workers and the level of distress among health workers, and also how confident they are to actually take care of COVID-19 patients, and how prepared they were to carry out or to take care of COVID-19 patients. And then we look at the factors associated with burnout and then also with distress. So we identified some major gaps in literature, that the studies that has been done at the time were mainly from developed world, and few studies were from Africa. So that's why we wanted to do this study in Africa. And this is the conceptual framework. We wanted to see if these healthcare worker related factors are going to predict burnout, and also if these facility factors are going to predict burnout as well as psychological distress. So this is our framework. We then did a study among all healthcare workers in Eswatini. So we targeted healthcare professionals, meaning those who had a training or training or any training in health. And also the facility Facebook page, as well as some healthcare workers then who completed the survey were forming part of the sample. So this was a cross-sectional online survey, and both private and public, meaning government-owned facilities and also other private facility were able to participate in the study. And we used convenience sampling and snowball sampling, whereby the healthcare workers have to send the questionnaire to friends who are also healthcare workers. And using a Poisson regression calculation, we found that we needed a minimum of 394 healthcare workers. And during sampling, as you can see, we were able to get about 486 healthcare workers. And in the country, there are about 4,000 healthcare workers in total, because Eswatini is a small country. So we're able to get about 4,486. And remember, the 4,000, not all of them are working in the clinical area or in the hospital. So we wanted to focus mainly on the hospital healthcare workers. And however, in the survey, about 11 people said that they are not currently employed, yet we wanted people who are currently employed. Also, about 475 people were retained, and then 22 were duplicates or similar answers. So the same people, because of network, maybe they said more than once. So we removed those, and eventually we were able to remain with about 450 participants, which we analyzed their data. So I've already said that the healthcare workers have to be more than 18 years to participate. They have to be working in the clinical area and be in a public or private sector. And they have to have more than 1 month experience. And also they have to be in a clinical setting. So if they are not clinical, they're excluded. These are the questionnaire that we used. So we asked about demographic information. We also asked about how confident with one item from the study, about how confident the headcounts, and about 4 questions asking them how prepared their facility is to manage COVID-19 patients. And we wanted to know their willingness to work during the pandemic, 1 item, and we had about 2 items asking about from these studies that are widely used in literature. And also 2 items asking about depression and anxiety called psychological distress items from the PHQ-4 item. We pre-tested the questionnaire among 10 registered nurses who are students at the University of Eswatini. So these students were able to give feedback on the length and also on the relevance of the questions, which they said it is positively said it was okay. So we then administered the instrument after getting ethical clearance from the research board of the Eswatini Ministry of Health. And for consent here, it was implied because as long as someone sent back the answers, it means they consent that they are agreeing to participate. We collected the data between 2 December and January 15, so about less than a month. This was the time, as you can see in this graph, the cases rise. So we actually did the study at the time when the cases were doubling, or severe cases of COVID-19 in the country. So the healthcare workers were really affected during this time. And we used Google Form to embed the questionnaire. So we link via Google Form where they put they responded to the questionnaire, and we sent 2 reminders. So we sent 1 reminder around December 28, and also 1 reminder around January 8. to say they must complete the questionnaire, so we're able to get responses. So again, we use data to analyze the data, and we used simple regression models and selected factors that are associated with the variables, and the similar methods we used before, we use them also for this particular analysis. So I won't go back and describe the methods because they're the same methods. Our findings, we found that about 37% of the participants were aged 30 to 39 years, and they were female, because in Eswatini we have more females as well. Also in most of them were nurses, so more females. And also the current status of marital status was single, they were never married. And a majority of them have bachelor's degree, and they were registered nurses. And we had about 5% doctors and about 6% nursing assistant. And about the other cadre here, it includes the paramedic, it includes the laboratory personnel and what have you. And about 20% of the workers said that they have some chronic illness. And 66% said that they have received some training formally, either via a workshop, maybe their employer give a workshop on how to manage COVID-19 patients. And about 43% said that they have actually cared or taken care of COVID-19 patients. About 41% were from government health centers. So you can see, if you combine these two, about 62% of these people were from the government facilities, and about 17% were from the religious organizations. And you can see that majority of them were from the urban area. It's because in Eswatini, most facilities are located in the urban area. Also, you can see this region, the most affected region, there were more workers from this region with severe COVID-19. And because also this region has more facilities as well. And also here you can see that about 64% of the nursing, of the healthcare workers say that their facility is a facility that takes care of COVID-19. So majority of them were from facilities that are taking care of COVID-19 patients or testing for COVID-19 patients. And then about 71% said that their facility has some guideline or protocol for COVID-19 management. We wanted to know where were healthcare workers getting their information about COVID-19. You can see here that majority of them say that they learn about COVID-19 from the workshop. Because these are people who are scientific people or scientists, you expect that they would say journals are the ones that are majority, but no, journals were the least source of information for healthcare workers. Yet the media was number 2, second highest. So it was surprising that the journals, scientific journals, is the least source. And also, if you can see here, we asked them how well do they feel informed about COVID-19. You can see that about 61% said they feel well informed. And also we asked them, have they ever experienced any symptoms of COVID-19? You can see a majority of them have experienced COVID-19 symptoms. However, I wanted to know how many of them have tested. So you can see here about 10% said yes, they've tested and they tested positive. Majority of them had never tested, and only 3 people actually have pending results. And then we wanted to know, because remember the healthcare workers went on strike to say they want to get more money, for the government must pay them more for working during COVID-19. So we wanted to know, do they think that they deserve to be paid more? You can see here that about 86% of them said yes, all healthcare workers must get extra pay or some extra money for working during COVID. Only about 11% said that only those in the front line deserve, but overwhelmingly, all of them are saying, most of them are saying that they need extra pay. And you can see here also, we wanted to know now, because vaccinations were coming their way. Actually, by this time, the government had already announced that vaccines are coming and healthcare workers will be the first one to get the COVID-19. So we wanted to know, are they willing to get the vaccine? You can see here that a majority of them, you can see that only about 38% said that they are willing to accept the vaccine, while about 36% said that they are not sure. So these are people are concerned about. So majority of the people are still not sure and all are not willing at all to participate. So we asked them how easy or difficult to avoid contracting COVID-19 at work. About 48 or 49% said it is very difficult for them. Said they never have PPE or they rarely have PPE, which was a serious concern for the country. Also, we asked them, do you strictly follow all the COVID-19 measures? We can see here that a majority says they sometimes of them have repeated mask or have to wear the same mask over many days. Here you can see a majority say they sometimes more than one time, like many days during the pandemic, even though their healthcare workers went at work. And we asked them about the gowns. Do you repeat the gowns? Yes. About majority said no, they never or rarely repeat the gown, but you can see about 34% say they still sometimes or usually repeat the gown. And we also asked them how well prepared they are. So these questions here we're just asking about, are you prepared to intubate a patient? Is your facility prepared to take care of COVID-19 patients? Do you know how to wear the PPE? So those kind of questions. So we can see here that a majority of the healthcare workers said that they are somewhat prepared. Only a few were well prepared, which is 9%. And then we asked them, have you ever felt discriminated? Did you ever feel discriminated by the community or by your family member? You can see here that a majority of the healthcare workers say that they have been actually stigmatized by the family or community members during this time because they are healthcare workers. And also we asked them, are you willing to work during COVID-19? First of all, has increased. Also about 60% said that they are willing to continue to work during this pandemic, even though the situation is difficult. And they wanted to know, how about in future? In future, are you willing to work in a pandemic? About 62% said yes, they are willing to work in a pandemic in future. We asked them, because remember those newspaper articles, they say that nurses run away or doctors run away from patients. Wanted to know, have you ever avoided taking care of patients? About 32% said yes, they've avoided, even though a majority say they've never avoided the patients. And then we asked them about the confidence, how confident they are to take care of COVID-19 patients. You can see, even though it's second wave, but only about, or many people said that is slightly or somewhat confident. So they were still not confident enough to manage COVID-19 patients. And then these are the variables for burnout. So you can see that for this question, the first question is asking them now, how have you felt burnout or emotional exhaustion during the pandemic? You can see that most of them were here, meaning every day. And however, if they were asked if they've been irritable or careless towards people, most of them said never. So you can see then in the next slide here that the prevalence of burnout was actually high. About 54% of the healthcare workers, they have felt burnout during the COVID-19 pandemic. Then we conducted simple and multiple regression, Poisson regression to predict the behaviors, predict the factors associated with burnout. So you can see here that those healthcare workers who were married, actually, they had a lower risk of reporting psychological distress. However, healthcare workers who have symptoms of COVID-19, they had a higher risk of having psychological distress compared to those who never, if you adjust for all the variables in the model, other variables in the model. And you can see here that those who were newly employed, meaning they just started work during the COVID-19, meaning the new graduate students, they said that they have a higher risk of being of suffering distress during the pandemic, or of burnout during the pandemic. This table is about burnout, sorry. And then also you can see here that those who said that they slightly or somewhat confident to manage COVID-19, they had also higher risk of burnout than those who said that they were very confident. So these are the highest risk among these groups. And then remember, we also wanted to know about the psychological distress. So this was a continuous variable. So the mean score was 5 over 12 in total. So there were roughly about less than half of the people who felt distressed. So this is the linear regression to see which variables will be associated with the psychological distress. So this is linear regression. So you can see here that those people who tested positive for COVID-19, you can see that actually they have less score or lower scores for psychological distress. So meaning they were not reporting less distress, even though they test positive. Also, then you can see here that those people who believe that they need to be tested regularly, who tested negative, were the ones actually who had higher risk or higher scores for the distress. So which is actually opposite. You would expect that those who test positive maybe have higher distress, but maybe it's because those who are negative still, they are still worried that they are still going to get COVID. But those who are positive, maybe it's because for them, they already have COVID, so they have some antibodies, so they know how the disease can take course. But these ones who are negative, they don't know how they can be sick if they are sick, so they are still worried about that. And also here, you can see that those who believe that they should be tested, they need to test regularly for COVID-19, they were more likely to report distress or had higher scores of distress compared to those who said they did not believe. And here you can see also we were surprised to find that those who are living with a chronic illness, they had lower scores for distress. We're surprised also why would this be the case. Actually, right now we're doing another study, a qualitative study to find out some of the reasons for these findings. So we're finding out that the workers are saying that those who were having chronic diseases, they agreed among themselves that they should be moved away from the high risk area and go and work in the low risk area in COVID so that they cannot suffer the severe symptoms of COVID-19. And you can also see from this model that those who said that they rarely or sometimes or usually work down, they were actually also having lower scores of distress compared to those who never. Also, you can see here that those who report increased workload also have higher risk of the distress or higher scores for distress. And you can see here also that the newly graduate students who started employed during COVID, they have also even higher, the highest risk for the COVID-19, or the scores for them were very high. And you can also see here that those who experience some stigma, they also report more psychological distress. And you can also see here that, however, those who had a higher score, who were more prepared, they were the ones actually who had the lower scores for distress, meaning they were less likely to suffer from depression or anxiety. So because they were well prepared. And this region, which is the one that is actually most affected, you can see that this region, from this region, they have higher, those with from this region, they had higher scores for distress, so they were more distressed, as well as those from the Lubombo region, also they had higher distress. This is the region that has the COVID-19 patients. Maybe that's why this finding. So in summary, in the recommendations, we are urging the Ministry of Health to educate the healthcare workers about COVID-19 and to sensitize them on which sources that are scientific for them, where they can go and find information, because we saw that most of them, they use social media and they don't use journals. Also, we are urging the Ministry of Health to strengthen or provide PPE, also to improve the preparedness of the facilities so that the facilities and the healthcare workers are able to manage COVID-19 patients. Also, we urge the Ministry of Health to initiate strategies or programs to motivate healthcare workers to be able to work during the pandemic, because they have high burnout, so they need to be motivated during the pandemic. And also that the ministry and the employers must provide the mental health services for the workers during the pandemic so that they can fight off the distress. And right now we are doing a qualitative study investigating why the workers are unwilling to take the vaccine and their experiences during the COVID-19. The strength is that this is the first study in Eswatini to do nationwide among healthcare workers, their experience during COVID, and that also we were able to capture the experiences during the second wave and at its highest peak. However, this is an online survey, so it's non-probability method, so selection bias is there. Also the low response rate, and also the findings are limited to those healthcare workers who responded to the interviews, to the questionnaire. This is a picture of Eswatini, so you're hoping one day you can come and visit Eswatini. This is how it looks like in the countryside. And with that, ladies and gentlemen, thank you so much. Terima kasih. This is my university in Eswatini, and this is my university in Taiwan. Thank you. Thank you, moderator, I'm done.
All right. Okay, such a beautiful picture. Yeah, I know Eswatini is a very beautiful country, and we hope all, inshallah, if we have time and opportunity, hopefully someday we can visit Eswatini someday.
Yes,
Mr. MDUDUZI, can you hear me?
Yes, hopefully, yes. You are most welcome, all of you.
Sorry.
I'm saying yes, you are most welcome to visit Eswatini anytime. Hello, Reski. Hello. Hello, can anyone hear me? Hello. I seem to have lost you, Reski.
Ini tidak aktif.
Unmute di situ kan? Sudah bisa? Hello, can you hear me?
Yes, now I can hear you.
Dengar juga, cuman
But I cannot hear them.
Can you hear me?
I'm sorry for the inconvenience. There is a technical error because of the Wi-Fi.
Oh, okay.
All right. Hello.
I can hear you.
Oh, okay. So after the presentation for the second topic of focusing on health workers regarding the impact of COVID-19 on the mental health and psychological problems among health workers. So now we move to the Q&A answer session also. So we will open same like the first session. So we will open like 3 questions for the first session. Because, sorry, I think we just have one session because we just have 15 minutes for Q&A session. So, raise your hand if you have any question for Mr. Speaker. Please, anyone want to have a questions? Can you check? Bisa dicek yang bertanya siapa? Ada? Okay, so Ibu Yusriani, please, time is yours.
Okay, thank you for your attention. Assalamualaikum warahmatullahi wabarakatuh. Thanks for giving me a golden chance to question about what form of psychosocial and behavioral investigation are being carried out in your country in the face of COVID. Thank you.
Thank you so much for your question. Did you got it, Mr. Speaker? For
Yes.
the first question.
Yes.
All right, thank you so much. So we still have 2 more questions. Please raise your hand on Zoom if you have any question to the Mr. Speaker. Irnawati, please, time is yours.
Okay, all right. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Okay, thank you very much to time. It is a really interesting material. Thank you, Mr. MDUDUZI. May Allah reward you with kindness. Before introducing myself.
Sorry. Okay,
Hello?
Irnawati, can you please introduce yourself, right?
Yes.
Before the question. All right, thank you.
Okay. Introducing myself. Myself is Irnawati. You can call me Irna. Before introducing myself, this is my question. COVID-19 related vaccine acceptance. How do you respond to people who refuse to be given the COVID-19 vaccine because people are afraid? And what is your best way to convince the community that giving the COVID-19 vaccine is important for protection from viruses? Hello.
Okay, yes, got it. Thank you.
Okay, can you please introduce yourself, Irnawati? Where are you from? Your affiliation? Okay, all right. Thank you so much, Mrs. Irnawati, for your wonderful questions. So now, please, Nur Ulan, time is yours.
All right. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam
warahmatullahi wabarakatuh.
First, I want to say thanks for the Mr. MDUDUZI who have given a best presentation today. And then I have some questions. The first is I see from the data, 50% of health workers have felt discriminated against. How is the stress management of health workers about this, and why there are still people there who don't want to receive vaccine. What is the cause? Thank you so much.
Okay, thank you so much, Mrs. Nurwulan. Introduce yourself a little bit.
Okay, my name is Nurwulan Sari. I'm from nursing student. I'm a nursing student. Thank you.
All right. So she's a nursing student from Faculty of Public Health at Muslim University, Indonesia. So now we already have 3 questions, Mr. Mdu. So please, time is yours to answer all the questions. Thank you.
All right. Thank you so much, moderator, and thank you so much for the wonderful questions and for your kind words towards the presentation. I will start with the first question on what psychosocial and behavioral investigations are carried out in the country. I would say that because I also sit in the National Health Research Review Board, so I am able to see all the studies that come through the country. So I can tell that, oh, the study is already done or not. I have some information about that. So I can safely say to you right now, in terms of research, actually very, very few people are conducting research. 1 or 2 people, like I'm among the first few to conduct the research during COVID-19. Many people do not conduct research because there's a lockdown. 2, there's less of resources, lack of resources to do the research. 3, most research is done by organizations like those that are funded by PEPFAR. The government doesn't do much research. So, however, those organizations during the COVID-19, they closed down or they have limited working hours. So they are not doing much research during this time. So basically, in terms of research, there is nothing much occurring except what you are seeing me reporting here, actually. The only investigation maybe that will be going on maybe would be at program level, or the Minister of Health, maybe some public health unit, maybe they are asking people like reporting some data from the facilities, but also it's just only for planning purposes, but not for research. So in terms of research, there's nothing much occurring in the country. And then the second question was how to respond to people who refuse to take the COVID-19. That's a very interesting question, especially because the main aim of the COVID-19 vaccination is to achieve herd immunity. So the higher the percentage of people we have who vaccinate, the more the chance for us to be able to open up and go back to normal. Unfortunately, in biomedical science, as you know, in biomedical science, it is unethical to force someone to take medication they don't want. Even though constitutions, even the Eswatini constitution says that someone cannot refuse some treatment, but is in relation to treatment, some treatment, if it's for public safety, but for the COVID-19, there's no way the government is going to force anyone in our country to take the vaccine. So the only way we can do to convince people is that we actually educate the people so that whatever reason they have for them to refuse, they can now have the information to decide to take the vaccine or not. So we are hoping that if we do more education, people can learn more about the safety of the vaccine and they can be willing to take the vaccine. And it's actually not unusual, it's common that when a new vaccine is introduced, or like HIV treatment before, some people actually can not be willing to take the vaccine. And also you asked, someone asked to say, so right now the government in Eswatini, the government said if some healthcare worker will refuse to take the vaccine, they won't force the healthcare worker. They will just try to persuade or to ask them to take the vaccine. And then someone asked, is there anything done for the people who feel discriminated? Unfortunately, I must say that, as I told you, that actually already we do a qualitative study to find out why the healthcare workers, they feel like this. I have not yet analyzed the data, but I was the one doing the interviews. we were able to interview about 34 healthcare workers from all over the country, to interview them and ask them questions. Why don't you want to take the vaccine? And we asked them, is the government or employer providing you with any mental service? I am disappointed to report to you that many of the healthcare workers say that the employer did not give them anything, no mental health support. So they are just on their own, nobody provides them with mental support. So we submitted the results for this study to the Minister of Health. We are hoping that they will see this and they will do something about it. And you also asked, why do the healthcare workers don't want to take the vaccine? So in the qualitative study that I did not report about here, the healthcare workers were saying that they don't want to take the vaccine for now because they are not sure about the long-term effect of the vaccine. They make example that the vaccine were only tested around less than a year, so they are not sure what will happen after 5 years. Is the vaccine still safe after 5 years? So they are worried about that. That is the main reason why they think they don't want to take the vaccine, because they don't know right now what is the long-term effect. But others, they say they don't want to take it because they already have suffered from COVID-19 before. They already get infected. So they think they have antibodies for COVID-19. So why they want to take the vaccine? So those are some of the reasons that came out from the study. Some people also, just because of misconception, they don't want to take it. They are not informed about COVID-19. Thank you, moderator. Hello, moderator.
Okay, so sorry. I was lost connection. So are you ready to answer all the questions?
I've already answered all the questions, yes.
So you already answered all the questions. Sorry, because I was disconnected before, so I didn't hear it. Sorry.
Oh, sorry, yes, I've already answered all the questions. The first question was that, is there anything? Yes, the first question, the answer was for the first question, nothing is done in behavioral investigation in terms of research right now. The second question, it is unethical for us to have to force someone to take the COVID-19 vaccine. So the government will not force anyone. We can only persuade or ask them to keep on asking them to take it, and we educate them on the safety of the vaccine. And the last answer to the last question, for those who suffer from discrimination or distress, the healthcare workers are not getting any help right now. And also that they refuse to take vaccines because they think that they don't know the long-term effect of the vaccine.
All right, thank you so much for your answer. And I hope all the one who asked questions get the benefits from the answer from the Mr. Speaker. And finally, right, we are in the end of this session of the guest lecture today. So I stated that this beautiful virus, based on the public health experts say it is beautiful virus, but actually can really highly contagious, right? And for the health workers, they are more vulnerable with this disease, with this virus, and they are more vulnerable for the effect of mental health problems on them, because they are the first person who are served the COVID-19 patients, and also they are working how to say overload, or they are working like more than the hours than the normal conditions. So that's why they are get more distress because of this pandemic. And also I also read it and also of course because of they should wearing like such as uncomfortable like clothes when serving the patient, right? And should wear still there.
I am still here, but I lost you at some point. I cannot hear you now.
Sudah bisa, Kak? Sorry, Mr. MDUDUZI, can you hear me?
Yes, now I can hear you, but I lost you.
Sorry. Oh my God, sorry. So we lost the connection again.
Yes, you were just saying that the coronavirus, even though it's like we were just talking about the beautiful virus and then something like that. Yeah, that's where I lost you.
Coronavirus is a beautiful virus, but actually it's very highly contagious. So, and especially this situation, like because of the pandemic, like can give a very, very big effect to our mental health and psychological behavior, especially for the health workers, right? Yes. Okay. Please I want to give some summarize in Bahasa Indonesia. So
no problem,
don't go anywhere, please.
No problem.
Okay.
Because
we want to give some like a certificate of appreciation after this summarize. Just a short summarize.
No problem.
Okay.
Thank you.
Okay. Jadi kita bisa dapat simpulkan dari apa yang disampaikan oleh pemateri dari materi pertama, yaitu penelitiannya itu dilakukan secara cross sectional study, ya, population base melalui lewat telepon. Jadi mereka menginterview 1.003 remaja ya di atas 18 tahun, general public, masyarakat umum. Dan mereka menemukan bahwa masyarakat yang memiliki pengetahuan dan attitude yang baik terhadap isu COVID ini, maka mereka cenderung terbebas atau jauh dari potensi untuk terkena COVID-19. Dan kita sebagai pelajar, ya, apa fungsi kita sehingga kita bisa istilahnya untuk memberikan partisipasi untuk mencegah atau mengontrol pengendalian laju COVID ini, sekaligus untuk mengontrol masalah efek dari mental health problem dari COVID-19 ini, yaitu dengan cara kita memberikan model yang baik, misalnya kepada masyarakat bahwa misalnya memakai masker itu wajib ketika kita keluar rumah. Kemudian mengedukasi people, ya, tadi yaitu dengan model behavior, dan kemudian kita mengedukasi masyarakat, dan kemudian tadi ada poin yang menarik yang disampaikan oleh Mr. Speaker, kalau katanya partisipasi kita dalam menjelaskan partisipasi kita dalam penelitian terkait COVID ini sangat penting, sehingga kita memberikan informasi yang jelas kepada masyarakat sekitar. Oke, dan terkait penelitian kedua, jadi penelitian ini dilakukan pada 450 perawat di Eswatini, dan menyatakan bahwa memang perawat itu jauh lebih memiliki vulnerable atau jauh memiliki potensi untuk memperoleh atau mendapatkan masalah mental, yaitu diakibatkan karena misalnya diskriminasi. Jadi ya kita sebagai masyarakat, apabila kita memiliki keluarga seorang perawat, ya, atau teman dekat seorang perawat atau health professional yang lainnya, jadi coba kita untuk tidak memberikan sebuah perilaku diskriminasi supaya tidak menambah beban mental mereka. Jadi ya mungkin itu saja yang dapat saya simpulkan dari dua topik yang disampaikan oleh guest speaker pada hari ini, ya. Dan okay, thank you so much for all the participants, and once again we would like to express our greatest thanks to Mr. Guest Speaker, Mr. MDUDUZI. So as an appreciation because of your time, right? Because of your knowledge that you already shared to us, we would like to give you a certificate as an appreciation. All right, so probably
Thank you so
I
much.
will be your representative to receive your certificate from our Dean, Faculty of Public Health.
Thank
All
you
right,
so much.
and
Thank you.
yeah, I'm so sorry we cannot give you for sickly for the certificate. I will send you by email.
No problem.
And then you can print it, right?
Yes, thank you.
Thank you so much.
Thank you so much.
This is the ceremony for like I'm as your representative to receive the certificate as appreciation for your time and for your knowledge.
Wow.
Yeah.
Thank you.
This is your certificate. We would like to say again, thank you so much for your time. And for the participants also, you can celebrate because our guest lecture is run very well. And tomorrow is our faculty anniversary. So happy birthday to Faculty of Public Health, Universitas Muslim Indonesia.
Thank you.
Yeah. So this is your certificate. Thank you so much.
Thank you so much for your kindness.
Thank you so much. And for all participants, all attendees also, we would like to say thank you so much for your participation. Thank you so much for your time watching us until this guest lecture finish. And as I remember, like more than 400, almost 500 participants attend this international guest lecture. And our dean say we welcome you, very welcome to come to our university, and I hope in the near future we can have some collaboration in the research or anything.
Yes, definitely. Yeah. Thank you so much to the dean. Actually, you know, Reski, I want to visit Indonesia with my wife sometime in the future. So yes, I'm looking forward, and I will pass by university.
Thank you so much, Mr. MDUDUZI.
Thank you.
Yeah, thank you so much. So I hope everyone can, of course, I believe we already enrich our knowledge about the COVID-19, about the impact of COVID-19 regarding the social, behavioral, and mental health issues. Thank you so much once again to all the participants and Mr. MDUDUZI. Thank you so much.
Thank you so much for the wonderful moderation, Reski. Thank you, and thank you, everybody.
All right, thank you so much. And all participants also can shake your hand to the camera and say thank you so much to Mr. MDUDUZI.
Thank you, thank you.
Thank you so much, Mr. MDUDUZI.
Thank you so much. Bye-bye.
Bye-bye. Thank you so much. Alright, so all participants, jadi saya serahkan kembali ke Master of Ceremony. Terima kasih.
Ayo.
Bapak mau dulu closing statement dari pimpinan. Apa kamunya? Acaranya nih ya?
Langsung.
Oh, saya langsung.
Iya.
Oh, iya. Baik.
On you, Pak.
Baik, Bismillahirrahmanirrahim.
Kasih mic.
Baik, bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Jadi tadi sudah diselenggarakan dari pagi sampai menjelang siang. Kita masih diberi kesehatan, diberi kekuatan untuk kembali bersama setelah ditutup oleh moderator dengan beberapa kesimpulan, dan kita sudah mengapresiasi kepada pemateri, ya. Dan selaku pimpinan fakultas, saya sangat berterima kasih banyak, terutama kepada Ketua Program Studi Kesehatan Masyarakat dan Sekretaris serta panitia kuliah tamu ini, ya, yang bertaraf internasional. Saya sangat bangga, ya, saya sangat berterima kasih sekali, meskipun persiapan, kalau boleh dikatakan persiapan yang ini, ya, tapi luar biasa, ya, luar biasa kerjasama panitia dan prodi. Tak lupa saya mengucapkan kepada seluruh peserta partisipan yang sempat bergabung. Kalau saya tidak salah tadi hampir 500, ya. Jadi ini luar biasa keanunya, ya, luar biasa kerjanya ke prodi ini. Saya mengucapkan terima kasih banyak. Semoga apa yang kita diskusikan hari ini bermanfaat buat diri kita, buat keilmuan kita, dan lebih-lebih kepada program studi dan fakultas FKM UMI, insya Allah. Dan semoga apa yang kita lakukan hari ini bernilai ibadah di sisi Allah Subhanahu wa Ta'ala dan memberi berkah buat kita bersama. Jadi saya tutup kegiatan ini. Ya, nanti panitia yang ada. Ya. Jadi saya tutup kegiatan ini dengan mengucapkan alhamdulillahirabbil alamin. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Bapak Ibu hadirin yang kami hormati, terima kasih kami ucapkan kepada guest speaker kita pada hari ini telah membawakan materi. Kemudian kami ucapkan juga terima kasih kepada moderator, Bapak Ibu dan semua partisipan atau peserta yang mengikuti International Guest Lecture pada hari ini, dan kami informasikan bahwa besok insya Allah akan dilaksanakan Milad Fakultas Kesehatan Masyarakat Universitas Muslim Indonesia yang ke-19 tahun. Bapak Ibu dan semua peserta bisa turut berpartisipasi secara virtual dan luring. Nanti akan di-share kembali meeting ID dan passcode-nya untuk Bapak Ibu dan semua peserta partisipasi untuk bisa mengikuti kegiatan Milad besok. Dan sekali lagi kami ucapkan terima kasih atas partisipasi mengikuti kegiatan hari ini. Semoga kegiatan hari ini bermanfaat bagi kita semua. Kurang dan lebihnya mohon dimaafkan. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. Ya. Kami informasikan kepada seluruh peserta untuk meng-on-kan kameranya karena kita akan melakukan screenshot. Ya, untuk lembaran pertama, Kak sudah siap lembaran pertama?
Biar kita di situ jadi kita.
Luar biasa. Kalau orang pintar memang itu cerdas adunya.
Dan tidak pandai bicara, sukses saja.
Kerjaannya bilang. Panas pertama yang ini jadi kesan ke depan kalau kita pandemi itu.
Pandemi.
Iya.
Panggil Pak Wira satu no. Siapa? Kita. Panggil Pak Wira satu ya.
Nanti foto dulu Pak. Sibuk. Dia lupa tadi juga dia sudah janji dari malam, dia lupa lagi. Orang pilih butuh ternyata belum. Ya. Ya, sama. Saya buat foto juga di sana.
Iya, Pak. Iya.
Saya mengaku sama Kak Prodi toh. Saya sama Kak Prodi toh. Bapak di sini ada masuk.
Senyum di dalam masker ya. Tidak kelihatan senyumnya.
Gak ada gunanya kita senyum juga.
Sukses ke depannya. Lakukan lagi.
Ya.
Nanti kalau di akhir Afrika kasih banyak-banyak.
Oh iya, insyaallah.
Saya 2 hari tidak bisa.
3 hari ini.
Itu saya bilang sempat tahu dirasa bantuan ya tapi ya itu konsekuensinya tuh. Insyaallah. Nanti administrasinya tolong ya.
Iya, sudah berita acaranya apa semua sudah. Iya.
Nanti berita acaranya.
Alhamdulillah.